very good evening and thanks to everyone for joining us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services and Mr. S. Ramkumar, Zonal Sales Manager, South Zone from NARI Division of Jagsonpal Pharmaceuticals Ltd, are very pleased to welcome you all to the webinar, ABHYAS, organized by Andhra Pradesh OBS and Gyne Society, jointly with OBS and Gyne Societies of Bijapur, Bellary, Ajmer, and Alwar. The academic partner for today's program is NARI Division of Jagsonpal Pharmaceuticals Ltd, makers of ProRetro 10 mg tablets of micronized dydrogesterone, indigenously assisting motherhood, delivering happiness, along with Cystelia-M, formulated with the ideal 40:1 ratio of myoinositol and D-chiroinositol, L-methylfolate, and vitamin D3 to restore ovulation and reproductive health in women, and Endoreg 2 mg tablets of Dienogest for the medical management of endometriosis and endometriosis-associated pelvic pain. A warm and hearty welcome to all the esteemed faculty and attendees. Dear attendees, please post your questions, suggestions, or clarifications in the Q&A box to be answered by the experts. Please note this webinar is streaming live on the Facebook and the link has been shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights, as the recording will be uploaded there. Now, let us welcome convener of the program, Dr. Uma Shankar, Secretary, Guntur OBS and Gyne Society, and Secretary, Andhra Pradesh OBS and Gyne Society, to kindly initiate this virtual program. Over to you, sir.
Good evening, one and all. I thank Jagsonpal for organizing this ABHYAS series of webinar. And we have our President, Dr. Venkatesh Alwar, as a chief guest. I welcome all members of all the societies, the presidents, to this ABHYAS webinar. The concept of ABHYAS will be told to you. But before that, we will have our lamp lightning.
Shubham kurutvam kalyanam arogyam dhana sampadah shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute.
The concept of ABHYAS series of webinar is to include each topic of OBGY into the webinars. It also wants to include a part of spirituality into one and all. The unique method of organizing it is mixing up societies of different parts of India to share our experiences and our local practices, and to strengthen our FOXy as such. With this, I would like to introduce our chief guest for today, Mr. Dr. Venkatesh Alwar, our president. Dr. Venkatesh Alwar is a professor HOD of Guntur Medical College. His field of interest is high-risk pregnancy and infertility. He is a past president of Andhra Pradesh OBS and Gyne Society, organizing chairperson of AP State APCOG 2019, conducted many CMAs and workshops. He has presented many papers in national and state conferences. He has many publications, international and national journals. He is examiner for UG and PG in various South Indian universities, participated in many social health programs, past IMA member of Guntur branch, conducted many teaching programs in national and state level, and sports is university player in TT and cricket, and he is a loved teacher by all the postgraduates in Guntur Medical College. Sir, I would like to request you to say a few words and we go to the main session.
So thank you very much. Can you hear me, Uma Shankar?
Yes, yeah, I can hear you, sir. We can hear you.
So thank you very much for welcoming us. And it's a very nice program. The ABHYAS, as you told, it includes includes all the various topics which will be discussed in obstetrics and gynecology. And I welcome the Bijapur Society, Bellary Society, Ajmer, and Alwar Society for including this academic program. So today is a variety of practical topics will be discussed. So I thank Uma Shankar for involving me so that I will be I can hear the various topics which are discussed. There are various speakers like from different places. So today I think the induction of labor and labor augmentation will be discussed. And because this induction of labor is itself a big question mark for any obstetrician, whether to induce or not, and whether to augment or not. All these are the problems, and what are all the various high risk groups which can be included in this also, which will be discussed. So we welcome the speaker, Richa Gupta. Next, I think we will be discussing about the vaccination in reproductive age women. The vaccination like rubella and Boostrix, the vaccination in women, particularly HPV vaccine for all the reproductive women, so that the prevention of cancer is one of the important things can be discussed. And after that, the miscarriages that occurs in the IVF, the various aspects will be discussed by Harsha Ravuri and Sri Harsha. So so they are very good speakers. So we welcome all the presidents and secretaries from all the societies. So today, I think there will be a good a group discussion, and a lot of points will be discussed. So thank you very much for involving Uma Shankar. So thank you very much. Thank you all. And all the best to all the speakers.
Now I introduce our president of Andhra Pradesh Obs and Gynae Society, Dr. Ganga Madam. Madam will be joining us shortly. She is a practitioner in Rajahmundry for last 3 decades, and she is the current president of APOGS. I welcome Ajmer President Dr. Preetam Kothari, Secretary Dr. Ajay Sharma. Welcome, sir. Alwar President Dr. Richa Gupta, Secretary Dr. Akrit Jha. It's a pleasure to have you all here. Bijapur President, my teacher, beloved teacher, Subhash Mudunar sir. He is an excellent teacher and he has taught us excellent surgical skills. I'm always indebted to you, sir, for teaching me and making me a good student. Thank you, sir. I welcome you, sir. And Secretary Rajeshri Yaliwal. Welcome you, madam, for this webinar. From Bellary, President Dr. Jagsonpal Gaur. Sir, it's 5 years I have traveled through Bellary. Morning 6 o'clock, our bus used to reach Bellary. From there, we used to proceed to Davangere. It's a pleasure to have you sir, with us. And Secretary Usha Rani. With this, we go to the main program. Welcome, madam. The first topic, I'll introduce the chairperson. Induction of labor. The government is now taking seriously the growing rates of cesarean section and is almost. Good morning, sir. Sir, I'm not welcome.
Yeah, good evening.
Good evening, sir.
Hello.
So 1 minute.
Can you hear
Hello,
me?
sir?
Yeah.
Yes, sir, we can hear you, sir.
Yeah.
So 1 minute, sir. I'll just give the introduction of the topic and you can start.
Okay.
So,
see, today's problem is about a termination of the IUD 24 below 24 weeks.
yes, sir. So I welcome Dr. Jamunath Gaud, sir. Sir has completed MBBS 1978 and MD Gynec from WIMS Bellary. Started practicing in private hospital company since 1986. Received ultrasound and IUA training from Mumbai and Kerala. Started infertility since 1990. Life member of FOXY, ISAR, IAG. Socially conducting free eye camps since 1990. Conducted more than 20 such camps. Won Best IMA Gangavati President Award. Best Diamond President Award of Gangavati Lions Club. Conducted IUA workshop for rural gynecologists in Bellary district at Hospet in 2010. conducted state level Muscon ultrasound conference at Gangavati in 2015. I'll introduce Dr. Rama Garg, MS OBG, consultant Kamlesh Memorial Hospital, Holy Family Hospital, Hope Fertility, Vice President, Ajmer Society, and past Secretary, Ajmer Society, and a member of VISA. Please, Madam, start your session.
I welcome you all on the behalf of Ajmer Society. I am
Can you
given the
start, Madam? Can you do the full screen, Madam, by running the slideshow? Yeah, thank you.
I welcome you all on this webinar. I'm thankful to the Andhra Pradesh Society for giving me the chance of speaking in this interesting topic of induction of labor and augmentation of labor. Are they safe? Fear is the father of courage and mother of safety. So if we are fearful for the process, we will take extra step for the safety measures. And my topic is up to 24 weeks, and especially in cases of IUD. What is the induction of labor? We all know it's the stimulation of uterine contraction before the spontaneous onset of labor with or without ruptured membrane. And augmentation is the process of stimulation of uterine contraction that are already present but found to be inadequate. Important points to evaluate before we start induction. First, we consider maternal considerations, hypertensive disorders of pregnancy, preeclampsia or eclampsia, other medical disorders like liver, kidney, or any other fetal infections, premature rupture of membranes, chorioamnionitis. If it is there, we have to manage it first and then induce. Abnormal presentation, we have to evaluate the placental position before induction. RS sensitization, feto-maternal transfusion if has occurred. First, give immunity for it, injection anti-D, then start the process. Oligohydramnios should be considered. And contraindications, which if IUD is in near term and baby weight is more, then we have to see for the prior uterine scars of myomectomy, etc., or incision star cesareans. Active genital herpes, if it is there, we don't induce it. And previous VVF repair. If baby is very small, we can try, or if it's large baby of IUD, we don't try. Fetal considerations, compromised fetal, if there, we have to do induced labor. Fetal abnormality, congenital abnormality which cannot thrive the fetus even after surgery, or IUD. Social consideration, we have to consider sometimes rape and etc. for before 24 weeks. And congenitally malformed baby. What is important before induction? We have to see the cervical ripening. And cervical ripening takes place by enzymatic degradation, and which is influenced by hormones. Estrogen helps to ripe the cervix, progesterone inhibits the ripening of the cervix. Increased hyaluronic acid helps in ripening of cervix, and increased decorin. It also degrades the enzymes and cervix is ripened with the help of it. First, we will check for the modified Bishop score or Calder score. If the score is 0, it means cervical dilatation is 0, cervical length is 3 centimeter, station is -3, consistency of cervix is firm, position is posterior. The score is 1, well, cervical dilatation 1 to 2 centimeters, length 2 centimeters, station -2, consistency moderate, posterior of the cervix is inverse position. If score is 2, it's 3 to 4 centimeter dilatation, 1 centimeter length, presentation at -1 or 0 station, soft cervix with anterior position. If it's 3 plus, it's a 5 or more centimeter dilatation, less than 1 centimeter length, plus 1 station. Total score if 13 is good, favorable is 6 to 13, unfavorable is less than 5. Bishop score modifiers are if we can add 1 point for preeclampsia and each previous delivery. We can subtract 1 point for post-dated pregnancy, nulliparity, or pre-PROM, preterm premature rupture of membranes. Predictive factors for successful induction are period of gestation, near term it's more success, or post-term. Pre-induction score if it's more than 6. Sensitivity of uterus if it's positive oxytocin sensitivity, cervical ripening if favorable, and presentation of fetal fibronectin. Methods of cervical ripening are these are the most important things. Cervical ripening is the mainstay of induction of labor. And previously used or less frequently used methods are non-pharmacological. First is herbal supplements, evening primrose oil, blue and black cohosh. Second, raspberry leaves, wild ginger, pineapple. Third is breast stimulation. Fourth is castor oil, hot baths, enemas. Fifth is acupuncture, transcutaneous electrical nerve stimulation, sexual intercourse, muscle therapy. Results of these methods is not predictive, so we prefer other methods like mechanical methods of cervical ripening. Mechanical methods can be further divided into natural osmotic dilators, Laminaria japonica, Laminaria digitata, isabgol. Second is synthetic osmotic dilators, Lamisil, Delapen. Third is sweeping of membranes. Fourth is extra-amniotic Foley's catheter. Fifth is extra-amniotic saline infusion. Sixth is Panicker's rapid cervical dilators. In this diagram, there is laminaria tends for seen, and after when we introduce them in the closed os, after 24 hours, they swollen up and they dilate up to approximately 1 centimeter of the cervix is dilated. It can be more in some cases. Mechanical methods, other are they safe? Osmotic dilators, are they safe? Advantages is they are cheap, outpatient placement is possible, easy for placement, no need for fetal monitoring, rapid improvement of cervical status. In my case, because fetus is already, we are not considering, so we can use it. Disadvantages, need for skill proper placement in internal os, delay in obtaining maximum effect, patient discomfort is there, and lack of manufacturer specification, and incomplete sterility. Sometimes spores are there which are not sterilized by UV lights. Other mechanical method is sweeping of membrane, separation of membrane from lower uterine segment by a circular motion of finger, which is inserted through the cervix. It is associated with increased in circulating prostaglandins, percussions reflex, and reduces formal labor inductions. But it's uncomfortable and not possible when the cervix is closed for or very poor post-Bishop score. Mechanical methods, other is extra-amniotic Foley's catheter. It acts by physical stretching of cervix and prostaglandin release. Its effect is slower than prostaglandin E2, but it causes less uterine hyperstimulation and fetal heart rate changes. In this, we introduce Foley's catheter as shown in the diagram and inflate the balloon, and then we tie up the lower end of the balloon with some weight so that it creates a constant pull pressure on the cervix. Another mechanical method is extra-amniotic saline infusion. After placing the balloon, as in previous case, catheter saline is infused at the rate of 50 ml per hour. And it's more effective than using other exogenous products of stimulation. Now I'm showing this Panicker's cervical ripening device. It's a recent introduction, and it's a very, it seems to be a very useful device for us.
This is the soft silicone autoclavable and reusable cervical ripening device invented by me. The Foley's catheter is first introduced through this device and then into the extra amniotic space through the cervical canal, and the bulb is inflated. The sponge here represents the cervix. The Foley is introduced into the extra amniotic space like this, and then the bulb is inflated with 70 ml of saline and pulled down. The cervical ripening device is introduced through the vagina to press on the cervix like this, and the Foley's catheter is pulled down with force and fixed onto the side hole of the ripening device like this. So the bulb of the Foley and the ripening device exert a pressure effect on the cervix, which is sandwiched in between these two. This pressure will dilate the cervix like this, and when the dilatation is complete, the Foley's catheter, bulb and the device will slowly falls down through the vagina. This is very useful, very effective, very inexpensive technique of induction of labor.
Now the next is pharmacological methods. Prostaglandins E2 dinoprostone, prostaglandin E1 analog is misoprostol, prostaglandin F2 alpha, oxytocin, estrogen, relaxin, hyaluronic acid, progesterone receptor antagonist. The most important thing which we use is prostaglandin E1 analog misoprostol. These modulate the fibroblast activity and increase hyaluronic acid production. Acting as a chemotactic agent, inflammatory cells release degradative enzymes, causing cervical ripening. Unlike oxytocin, the response to prostaglandin does not change throughout gestation. Pharmacokinetics of mesoprostol are: its route of administration is oral, vaginal, and sublingual. Bioavailability is extensively absorbed from GIT. Metabolism de-esterified to prostaglandin F analogs. Half-life 20 to 40 minutes. Excretion mainly renal 80%. Maximum plasma concentration with 400 microgram misoprostol is achieved in 34 minutes after oral and 80 minutes after vaginal administration. Misoprostol used in IUD. According to WHO guidelines, 13 to 17 weeks, we can use 200 micrograms per vaginally 6 hourly. Maximum 4 doses can be given. 18 to 26 weeks, 100 micrograms per vaginal 6 hourly, maximum 4 doses. 7 weeks to term, 25 micrograms 6 hourly, maximum 6 doses. Or 20 to 25 micrograms per oral 2 hourly, maximum 12 doses. NICE guideline says before 27 weeks, 100 micrograms 6 hourly. After 27 weeks, 20 to 50 microgram 4 hourly. FIGO misoprostol only regime tells 13 to 26 weeks, 200 micrograms per vaginally or buccal every 4 to 6 hours. 27 to 28 weeks gestation, 100 micrograms per vaginally, sublingually or buccally every 4 to 6 hours. After 28 weeks, 25 micrograms per vaginally 6 hourly, 25 micrograms 2 hourly. For previous LSCS cases, misoprostol can be used in reduced doses with careful monitoring. Now is the Dienogest Pg E2 analog. We are using it as a vaginal gel, piperidil or Cerviprime are the preparations available. Cerviprime is available 2.5 ml pre-filled syringe as shown in the diagram. It's a 0.5 mg of Dienogest. May be repeated every 6 hourly, maximum 3 doses in 24 hours, reduced the need of oxytocin augmentation. Dienogest vaginal insert is also available. It has 10 milligram of drug in a mesh placed in the posterior fornix of vagina for 24 hours. It releases medicine at the rate of 0.3 milligram per hour. Advantages: it may be removed with the onset of active labor, with the rupture of membranes, or with the development of uterine hyperstimulation. Cerviprime gel, when it's inserted, we cannot remove it, but in this we can remove. We can just pull the thread of the mesh. Complications: it's a hyperstimulation, meconium stained liquor if baby is alive, precipitate labor, rupture of uterus. Vaginal pessary, it's as effective as gel is as effective as tablets. This can be used. Advantages of prostaglandin E1 over Pg E2: misoprostol is cheap, Dienogest is costly, stable at room temperature, and Dienogest is unstable at room temperature. Long shelf life is of misoprostol. Dienogest requires refrigeration, easily administered orally or vaginally. And while Dienogest is intravaginal and intracervical administration needs skill, misoprostol has less side effect, it has more side effects. Induction delivery interval is short in misoprostol, while it's long in Cerviprime. Need for oxytocin augmentation is also less in misoprostol. Oxytocin, this is used successfully for both induction and augmentation of labor. We are using it for years. There are two types of regime: low dose and high dose. In low dose regime, 1 to 2 milliunit per minute. Dose is increased incrementally by 1 to 4 milliunits at 30 minutes interval. In high dose, it starts with 4 to 6 milliunits per minute with the dose increment of 4 to 6 milliunits per unit every 15 to 30 minutes. Safety in induction and augmentation, it's always be careful, ABC. For using any of the method, we have to be always careful. What we have to monitor: maternal vitals, uterine contractions, cervical response, progress of labor, maternal emotions, family worry to get IUD baby out of earliest, blood test monitoring as and when required in case of mother with medical disorders, IUD, other situations as they arise during the process. What are the dangers of induction of labor? Psychological upset when there is induction failure and cesarean section or hysterectomy is done. Tendency of prolonged labor due to abnormal uterine contractions. Increased morbidity, increased operative interference, or increased need of analgesia during labor. Thank you.
Before 24 weeks, this IUD management was previously when we were practicing, it was different. Means, we were not having drugs at all in around 40 years back, 35, 40 years back. Now there was only laminary tents were available. Then gradually it came to Foley's catheter. Then we used to give supplementation of oxytocin only. Then later on these drugs came and they appears to be very safe, and now there is no problem for IUD management before 24 weeks with medical management only. Most of the, so many MTBs we are avoiding only with the recent drug, and actually it is very welcoming for this newer version of medications, medical management of abortions, especially before 24 weeks. And we have to keep it in mind that previous cesarean and all, then we can use safely. And I think what I am experienced, vaginal as well as oral is one and the same. The results may be very different. Even we wait till 48 hours also, and there will be no much complications. And even then, after 48 hours, if the patient doesn't terminate, then we will go for dilatation and evacuation with syntocinon. Then this speaker, what she enlightened is very excellent, and she took all of us for everything, and it was very informative. Thank you, madam. Thank you.
Thank you, sir, for your wonderful comments. So now we invite our next chairperson, Dr. Shobha. She has done her MBBS, DGU and DNB. She has publications in national and international journals. She has reviewed 2 original articles in various journals, presented many papers in national, international level. She has invited faculty at national, state conferences and regional conference. She has special training in ultrasound and pregnancy, laparoscopy and infertility. Her areas of interest are teaching, high-risk pregnancy and management. Over to you, Dr. Shobha.
Very good evening, Richa Gupta madam. I want to introduce today's speaker, Richa Gupta ma'am. She is a senior consultant at City Hospital, Alwar. She is the president, Alwar Obstetrics and Gynecological Society for 2021 and 2022. She has received many awards, and madam is secretary of Alwar's Foxy branch for the year 2012 to 2017. And she has publications in various journals, and she has received Best Public Awareness Award on Women's Day. And she is the scientific secretary of Alwar Foxy branch. And even she has received Best Gynec Doctor Award from IMA Alwar. And she is interested in publications also. And madam is editor of Foxy Journal, Alwar. Over to you, ma'am. The topic is induction of labor at term.
Good evening, everyone. First of all, I will thank you. Thank you for giving me opportunity to share a good academic platform. My topic is induction and augmentation of labor. Are they safe? Induction of labor is initiation of uterine contraction artificially after the period of viability before onset of labor for the purpose of secure vaginal delivery. The rate of labor induction is steadily increasing, and in industrialized countries, approximately 1 out of 4 pregnant women has their labor induced. Induction of labor, why to induce? Induction of labor should be considered when the benefits of prompt vaginal delivery outweigh the maternal and or fetal risk of waiting for the spontaneous onset of labor. However, this procedure is not free of risk, which include an increase in operative vaginal or cesarean delivery and excessive uterine activity with risk of fetal heart rate abnormality. The aim of this presentation is to summarize the controversies concerning the indications, the methods, and the tools for evaluating the success of the procedure with an emphasis on the scientific evidence behind each. The indication of induction of labor, maternal or IUD, fetal malformation, polyhydramnios, Fetal indications are postdated pregnancy, intrauterine growth retardation, RH isoimmunization, unexplained IUD in prior pregnancy, diabetes mellitus. Combined indications are hypertensive disorders of pregnancy, chronic renal disease, essential hypertension, chronic pulmonary disease, premature rupture of membrane, chorioamnitis, abruptio placentae, incompatible with life, and obstetric cholestasis. Induction should be avoided if there are any contraindication to labor or vaginal delivery, which can be because of major degree of placenta previa, major degree of CPD, vasa previa, previous classical uterine incision, cephalopelvic disproportion because of abnormal pelvic bone structure, active genital herpes infection, invasive cervical carcinoma, hypersensitivity to cervical ripening agents, transverse tie, previous uterine rupture, previous pelvic surgery like BBF, RBF, pelvic floor repair. The indication and process of induction of labor should be discussed with the patient. The profile of the patient, medical or surgical conditions, rupture of membranes, scar on the uterus, cervical status, the specific method of induction of labor, and associated local resources in terms of health personnel, drugs, and equipment should be taken into consideration. Induction of labor should be done after obtaining informed written consent. Now we come for setting for induction of labor. All patients should be admitted for induction of labor in a healthy facility, having facilities for cesarean section and management of complications. Induction of labor should be done under necessary supervision. Maternal and fetal monitoring should be done, and the progress of labor should be documented. What are the prerequisite and pre-induction assessment? We should take informed written consent, review of maternal history and profile, evaluation for indication, and rule out any contraindications. Reliable estimation of gestational age, presentation, and fetal weight, maternal pulse, blood pressure, temperature, and respiratory rate, and findings on abdominal palpation must be recorded. Evaluation of baseline fetal heart rate pattern by auscultation or electronic fetal monitoring, maternal pelvis assessment, and clinical evaluation for possible CPD. Assessment of cervical status using modified Bishop scoring system to predict the likelihood of successful induction. Outcome of patient with a score of less than 6 was unfavorable. With a score of 9 to 10, all patients could be delivered within 4 hours and most within 24 hours. Now, we will going to discuss induction of labor in specific circumstances. First is prolonged or postdated pregnancy. This is a chart showing comparison of different guidelines. According to AUGMENTATION, offer induction of labor between 41 and 42 weeks. It reduces the perinatal mortality and meconium aspiration syndrome without increasing the cesarean section rate. Women who choose to delay induction more than 41 weeks, we should do twice weekly CTG for the assessment of fetal well-being. Same is in the WHO criteria, but and in NICE criteria and RCOG criteria. But in ACOG criteria and GCPR guideline and FOXI and ICOG guideline of 2018, induction of labor for a low-risk pregnancy is recommended to be carried out only after 39 weeks. In cases of pre-labor rupture of membrane, according to the SOGC, oxytocin should be considered before expectant management. GBS, if there is presence of GBS, start oxytocin as soon as possible and establish labor within 24 hours. We can use high and low dose oxytocin. According to WHO recommendation, IOL recommended for a woman with PROM at term, and IOL initiated less than 24 hours, oxytocin as the first option. ACOG recommends IOL to be initiated at the time of presentation to reduce the risk of chorioamnitis. Oxytocin infusion and intravaginal Pg E2 can be used. According to NICE guidelines, if gestational age is more than 37 weeks, offer a choice of induction of labor with vaginal PgO2 or expectant management. Induction of labor should be considered when there is duration of PRM is more than 24 hours. RCOG guideline recommend expectant management should not exceed more than 96 hours of PROM. In cases of preterm pre-labor rupture of membrane, ACOG guideline recommend if gestational age is less than 34 weeks, no IOL unless additional obstetric indication like infection or fetal compromise. If gestational age is more than 34 weeks, discuss risk to the woman like sepsis, possible need for cesarean section, risk to the baby like sepsis, problems relating to preterm birth, local availability of neonatal intensive care facilities. After discussing, we can do IOL with vaginal Pg E2. In cases of gestational diabetes, SOGC guideline recommend diabetes mellitus glucose control may dictate urgency. According to WHO, induction of labor before 41 weeks not recommended if only GDM. It is recommended with GDM with placental insufficiency or uncontrolled diabetes mellitus. According to ACOG recommendation, there is maternal medical conditions for IOL. It is a part of future research recommendation. RCOG recommend IOL prior to their estimated date for delivery. In cases of fetal macrosomia, induction should not be performed solely for suspected fecal macrosomia according to SOGC, WHO, ACOG, NICE, and RCOG. Another indication is maternal request. SOGC recommend induction should not be performed solely because of patient or care provider preference. NICE recommend not to routinely be offered on maternal request alone. Under exceptional circumstances, woman's partner is soon to be posted abroad with the armed forces. Induction may be considered at or after 40 weeks. RCOG guideline recommend where resources allowed, consider when there are compelling psychological or social reason and the woman has a favorable cervix. In cases of intrauterine device, WHO recommend in third trimester of pregnancy, dead of or anomalous fetus, oral or vaginal mesoprostol are recommended for induction of labor. According to ACOG recommendation, if gestational age is less than 28 weeks, vaginal mesoprostol high dose oxytocin infusion 200 to 400 microgram every 4 to 12 hours. If gestational age is more than 28 weeks, usual obstetric protocol is followed for induction of labor. According to NICE guidelines, there is a need for support for emotional and physical consequences. Offer immediate IOL if ruptured membrane, or you can prefer expectant management. Oral mifepristone or vaginal PgO2 or misoprostol can be used. In cases of previous cesarean section, SOG recommend prostaglandin E2, cervical and vaginal should not be used for BBAC, increased risk of uterine rupture. Misoprostol should not be used in the setting of vaginal birth after cesarean section because of increased risk of uterine rupture. Oxytocin can be considered. ACOG also recommend avoid use of misoprostol in previous LSCS or major surgery of uterus due to risk of rupture. NICE guideline recommend option of vaginal PGA2 cesarean section in cases of cesarean section and after informing the increased risk of LSCS or uterine rupture. FOXI guideline recommend the use of in women with the unfavorable cervix, use of mechanical methods like transcervical Foley's catheter is the preferred method for induction of labor, followed by amniotomy and oxytocin. Now we come to the recommended method for labor induction. Mechanical methods like natural and synthetic laminaria, balloon-tipped catheters or amniotomy. Pharmacological methods, most common use methods are oxytocin, ninoprostone, misoprostol. Less common use method are mifepristone, cytokines, nitric oxide, prostaglandin, relaxin, and tocosamine. What are the prerequisites for labor induction? The indication of induction must be documented and discussion should include reason for induction, method of induction, and risk, including failure to achieve labor and possible increased risk of cesarean section. If induction of labor is unsuccessful, the indication and method of induction should be reevaluated according to SOGC guidelines. WHO says outpatient induction of labor is not recommended for improving birth outcomes. According to ACOG, assess the cervix score to determine the likelihood of success and to select the appropriate method of induction. Document Bishop score. In cases of unfavorable cervix, higher failure rate in nulliparous patient, and there is increase of cesarean rate. Then use of mechanical method. SOGC recommend intracervical Foley's catheters are acceptable agents, safe both in the setting of a BVSC in the outpatient setting. Double lumen catheters may be considered a second-line alternative. According to WHO, balloon catheter is recommended for induction of labor. Balloon catheter plus oxytocin alternative method when prostaglandins, including misoprostol, are not available or contraindicated. According to ACOG, Foley's catheter is a reasonable and effective alternative. NICE guideline says that mechanical procedures like balloon catheters and laminar tent should not be used routinely. Now, another mechanical method, membrane sweeping, is recommended for reducing formal induction of labor according to WHO. According to NICE, prior to formal IOL, recommendation for PV and membrane stripping, additional membrane sweeping may be offered if labor does not start spontaneously 40 to 41 weeks in nulliparous women and more than 41 weeks for parous women. RCOG says that membrane sweeping is not associated with an increase in maternal or neonatal infection and is associated with increased level of discomfort during the examination and bleeding. Cervical ripening with pharmacological methods, the different guideline has different views. SOGC recommend misoprostol with intact membrane and or an inpatient basis. Oxytocin should be started no earlier than 4 hours after the last dose of misoprostol. After amniotomy, oxytocin should be commenced early in order to establish labor. WHO recommend oral misoprostol 25 microgram 2 hourly, low dose vaginal misoprostol 25 microgram 6 hourly, low doses of vaginal prostaglandin, no misoprostol in previous LSCS. ACOG recommend PGE analog, low and high dose oxytocin, tablet misoprostol 25 microgram, initial dose 3 to 6 hourly, intravaginal Pg E2 in PROM, risk of uterine rupture with misoprostol in previous LSCS, and misoprostol, if we use 50 microgram 6 hourly, there is increased risk of tachysystole and FSR changes. NICE recommend vaginal prostaglandin E2 tablets of gel 6 hourly, maximum 2 doses, controlled release pessaries 1 dose over 24 hours, misoprostol in IUD is under clinical trials, and mifepristone in IUD. RCOG recommend the use of oxytocin and vaginal PgO2. There is comparison of oxytocin with prostaglandin for induction of labor. In cases of intact membrane, PG in preference to oxytocin, rupture membrane, PG or oxytocin. Comparison of intracervical and intravaginal prostaglandins. Intravaginal prostaglandin in preference to intracervical, equally effective, and administration of vaginal PGE2 is less invasive. Comparison of different preparation of vaginal prostaglandins. Vaginal tablets should be considered in preference to gel formulation. Recommended regimen for vaginal PGE2. PGE2 tablets 3 mg 6 to 8 hourly, maximum 6 mg for all women. PGE2 gels 2 mg in nulliparous plus unfavorable cervix, Bishop's score less than 4, maximum 4 mg. Second dose of 1 to 2 mg. 1 mg for all other women. 6 hours later, maximum 3 mg. Comparison of different regime of oxytocin administration. Oxytocin not start till 6 hours following administration PGs. Amniotomy should be performed whereas feasible prior to commencement of infusion of oxytocin. Recommended regime for oxytocin is starting dose of 1 to 2 milliunit per minute, increased at intervals of 30 minutes. Maximum dose is 20 milliunit per minute. If higher doses are used, maximum dose used should not exceed 32 milliunit per minute. Methods not recommended for IOL, non-pharmacological methods like herbal supplements, acupuncture, castor oil, hot baths. pharmacological methods like oral Pg E2, intravenous Pg E2, extra-amniotic Pg E2, intracervical Pg E2, intravenous oxytocin alone. These are NICE guidelines. Then comes the monitoring during induction of labor. Wherever induction of labor occurs, facilities should be available for continuous uterine and fetal heart rate monitoring. Fetal well-being should be established immediately prior to induction of labor. Following induction of labor with vaginal prostaglandin, fetal well-being should be established once contractions are detected or reported. In cases of uncomplicated pregnancy, following administration of vaginal prostaglandin, initial assessment with continuous electronic fetal monitoring. Once normality is confirmed, intermittent monitoring can be used. With oxytocin, continuous electronic fetal monitoring should be done. Then comes the pain relief. Women should be informed of the availability of pain relief options. Women should be provided pain relief appropriate for them after counseling. This can range from simple analgesic to epidural analgesia. Women should be encouraged to use breathing and relaxation techniques in labor. There is no need to wait for labor analgesia arbitrarily till the cervical dilation has reached 4 to 5 centimeters. If given early in labor, it does not affect the progress of labor. Pethidine and opioid analgesia can be used for short-term pain relief, preferably in early labor, because induction of labor, induced labor is more painful than normal labor. Then we come to the risk associated with induction of labor. Maternal risk like failure leading to cesarean section, intrauterine infection, choriamnitis, increased risk of PPH, uterine hyperstimulation, rupture uterus, amniotic fluid embolism, precipitate labor, dysfunction labor, increased risk of operatic vaginal delivery, abruptio placentae, APH from undiagnosed placenta previa, water intoxication, fetal risk like fetal distress, fetal death, neonatal sepsis, iatrogenic delivery of a preterm infant, cord prolapse, neonatal jaundice, increased risk of birth trauma. Prolonged use of maternal facial oxygen therapy may be harmful to the fetus and should be avoided. Uterine hypercontractility with a suspicious or pathological cardiotocograph CTG secondary to oxytocin infusion, the oxytocin infusion should be decreased or discontinued. Abnormal fetal heart pattern and uterine hypercontractility not secondary to oxytocin infusion, tocolysis should be considered. Beta mimetics like suggested regime is subcutaneous terbutaline 0.25 milligram. Suspected or confirmed acute fetal compromise, delivery should be accomplished as soon as possible within 30 minutes. If uterine rupture is suspected during induced labor, the baby should be delivered by emergency cesarean section. What is failure of induction? According to NICE, failure to establish labor after one cycle of treatment consisting of the insertion of 2 vaginal Pg2 tablets, 3 milligram or gel 1 to 2 milligram at 6 hourly intervals or 1 Pg2 pastry 10 milligram within 24 hours. According to ACOG, allowing at least 12 to 18 hours of latent labor before diagnosing a failed induction may reduce the risk of cesarean delivery. WHO mentioned as not necessarily indicating CS but not specified. According to NICE guidelines, Tachistol is said when more than 5 contractions per 10 minutes for at least 20 minutes. According to ACOG and NICE guideline, the duration is 30 minutes. These are the 2 forms designed by FOXY. This is the consent form when we take any patient for induction of labor. And this is the checklist. These are designed by good clinical practice guidelines issued by FOXY ICOG in 2018. Now come the augmentation of the labor. Augmentation of the labor is the process of stimulating the uterus to increase the frequency, duration, and intensity of contraction after the onset of spontaneous labor. It has commonly been used to treat delayed labor when uterine contraction are assessed to be insufficiently strong. Prolonged labor is an important cause of maternal and perinatal mortality and morbidity. Thus, failure of labor to progress has become one of the leading indications for primary cesarean section. In this regard, the WHO published recommendation for induction of labor in 2011. The goal of the present guideline is to consolidate the guidance for effective interventions that are needed to reduce the global burden of prolonged labor and its consequences. This chart shows that what is recommended and what is not recommended in cases of prevention. For the prevention of delayed labor, active phase partograph with a 4-hour action line to monitor labor progress, routine assessments with digital vaginal examination at 4-hour intervals, encouraging mobility and upright position, and continuous companionship. Treatment is the use of oxytocin alone for treatment of delay in labor, the use of amniotomy and oxytocin for treatment of confirmed delay in labor. What should not be done? The use of a package of care for prevention of delay in labor, administration of an enema, the use of early amniotomy with early oxytocin augmentation, the use of amniotomy alone, pain relief for preventing delay, restricting fluid and food intake for women at low risk, the use of IV fluids to shorten labor. We should not do augmentation with IV oxytocin prior to confirmation of delay in labor. High starting and increment doses regime of oxytocin not used, the use of oral misoprostol, the use of amniotomy alone, the use of internal tocodinometry compared with external tocodinometry. So the conclusion is the purpose of this review is to give some food for thought, showing that the variables involved in the process are many and ideally should be evaluated on a case-by-case basis. The attempts made to create successful prediction systems implemented so far are still far from achieving the intended. In conclusion, some suggestion can be provided. It would be recommended that every birth center should be provided with local guidance regarding the IOL. Thank you.
Thank you, Dr. Richa Gupta, ma'am, for your elaborate various procedures for induction of labor. Almost ma'am has told all the guidelines, recent guidelines, what all we can use. Ma'am, in your practice, what you are doing? Are you inducing at 40 plus or at 41?
No, I am generally inducing in a high risk cases at 39 weeks, and when there is low risk cases after 40 weeks.
Yes, ma'am. Even after 40 weeks plus 2 or 3 days, also we are seeing more number of patients having
chances of meconium, and as we wait, there is chances of oligohydramnios.
Even oligohydramnios, cord compression, we can do. So what method you are using, ma'am?
I am using misoprostol, vaginal misoprostol.
So here
25 microgram every 3 to 4 hourly, maximum 3 to 4 doses, and followed by amniotomy and oxytocin.
Yes, ma'am.
And I am getting good results. I am practicing since 15 years.
Yes, ma'am.
20 years.
Here we are using Cerviprime gel for 3 doses, 6 hours apart. Even after 24 hours, if they don't get into active labor, then probably we may start her with oxytocin for 6 hours like that. Then if doesn't respond, then we will take her directly for C-section, because almost she has crossed 40 weeks and liker will be less at this period of gestation. And
I am using misoprostol. Cerviprim very rarely. In cases of IUD, I am using Cerviprim. And when there is Bishop score is 0, and in some cases, but
so when exactly
I am using misoprostol, vaginal misoprostol.
Yes, ma'am. In even artificial rupture of membrane, we should do at 3 to 4 centimeter of dilatation. Is it better, or very early again it is going to prolong, I think? But
in cases of post-dated pregnancy where we are doubtful whether there is meconium or not, then when there is 1 to 2 centimeter, I will prefer to do ARM.
Okay.
Because in some cases, ultrasound must be normal, but after rupture of membrane, CTG may be normal, but in some cases there may be thick meconium, and chances of cord compression is there.
Yes, ma'am. As you told, even monitoring of the patient after induction is also important, because You cannot just go on waiting for 24 hours, 48 hours with induction protocol. Once they start getting good contractions, at least 3 to 4 contractions in 10 minutes, each lasting for 40 to 45 seconds, at least 6 hours is enough, I think, for a decision.
Yeah.
If she is progressing with the descent and dilatation, then we can go ahead. Yes, very nice presentation, madam. Thank you. Thank you, Andhra Pradesh Society and Ajmer Society and other Bellary Society for giving me the chance. Thank you, ma'am.
Thank you.
Thank you, madam, for this wonderful session. Mark my words, madam. In the future, the government is coming up with a legislation to decrease the rate of sections. So the next 2-3 years later, all the webinars or topics will be on induction of labor only and legal aspects with it. So this is the beginning for ways to reduce the rate of cesarean section, because the government is very serious, and they have talked with our Shantakumari madam also. They want to bring down the cesarean section rates. Now it is around 55 to 60 to around 30%. So we must encourage more of normal deliveries. With this, we go to our next session.
Yeah, Umashankar, one point.
Sir. Yes, sir.
Very appropriate topic to be discussed, and the importance of induction and the cesarean rate, as you told. I think that will be the future, or what are the indications? So failed induction is a very vague term for everybody. So failed induction, all these things, unless the government is very specific of the induction indication. So for indication for cesarean section, very important. So you can't just put a vague terms and then maybe the indication for cesarean section. So induction of labor is a very an important topic, and all the things which you have discussed very nicely, madam. Congratulations, well done. Thank you.
Thank you.
I invite the next speaker, the next chairperson, Dr. Preetam Kothari. Madam, Dr. Preetam Kothari, yes. She is the president of Ajmer APOGS and Gynae Society. Welcome, madam. She is senior consultant at Mittal Hospital, Ajmer, director of Kothari IVF Center, Ajmer, endoscopic surgeon and IVF specialist, ex-professor, assistant professor, JLN Medical College, Ajmer. It's a pleasure and honor to have you here, madam.
Yeah, thank you. Good evening.
Can you introduce the speaker, madam? Yeah.
Good evening, all. First of all, thank you for giving me this opportunity by your society, AP Society, OBGY Society. Our next speaker, I am introducing Dr. Shiva Kumar SC. He is associate professor and Vijayanagara Institute of the Medical Science, Bellary. He is consultant Shiva Super Specialty Clinic, Bellary. He has got Best Poster Award in NatCon 2014 at Chennai for paper on primary peritoneal malignancies. He got third prize for the paper presentation on staging of the cervical cancer at NatCon 2017 in Bangalore, and second Indian Cancer Congress. Six publications in oncology in his name. The special interest is the breast and gynae oncology, and he is affiliated with all societies, IMA, HOA, ISO, and FOXY, and he is secretary KSC Obstetrics and Gynae Society, and 2021-23. So welcome, Dr. Shiva, and the desk is yours.
Thank you, Preetam madam, for the introduction. I thank Dr. Uma Sudhakar sir for giving me opportunity to share my knowledge on vaccination in reproductive age women. Preetam madam, I am audible?
Yeah, definitely.
I am audible. Okay. Thank you, madam. I also thank all the secretaries and presidents of all the OBG societies. A warm welcome from Vijayanagara Institute of Medical Science, Bellary, my own alumni, and Bellary OBG Society. The today's topic is vaccination in reproductive age women. In that, the part given to me is pertussis and rubella. So I put the heading as prevention of pertussis and rubella. Why vaccinate women is the first question. With the epidemic of COVID, we all know that vaccination will protect against the serious infection. So to protect against serious infection, especially during pandemics, this vaccination is required. Women should be vaccinated against the preventable disease in their environment prior to conception. The best example is rubella. If we get rubella, we can't do, especially during pregnancy, we can't do anything. So this infection can be prevented by vaccination. So women should be vaccinated against preventable disease in their environment prior to conception. Vaccination during pregnancy is warranted when the risk of exposure is high, the infection poses risk to the mother and or fetus, or vaccine is unlikely to be harmful. The best example is pertussis. The pertussis vaccine, if it is given in pregnancy, will protect the baby from the pertussis. So in vaccines in pregnancy, I am going to tell at the end of this session, we should be able to give answer to these questions. That is maternal vaccination necessary for protecting the baby against the pertussis, and whether the rubella in children can be eradicated or can be prevented. This chart shows all the vaccines which can be used during pregnancy, before pregnancy, and after pregnancy. The underlined vaccines, that is hepatitis, influenza, meningococcal, pneumococcal, Tdap, and tetanus and diphtheria vaccine can be given in pregnancy because they are attenuated vaccines. Whereas MMR vaccine and varicella vaccine are live attenuated vaccines. They should be better avoided during pregnancy. Tdap can be safely given during pregnancy to protect the fetus from pertussis. So preconceptional immunization, what is the rationale? Ideally, women should be vaccinated against the preventable disease in their environment prior to conception. Several infections with serious consequence for mother or fetus can be prevented by preconceptional vaccination. Ensuring immunity against measles, mumps, and rubella and varicella is important since these immunizations are contraindicated during pregnancy. Infection in non-immune pregnant women can adversely affect the pregnancy outcome. Preconceptional immunization, we should have some caution. What are these cautions? Before administering a live vaccine, it is a reasonable practice to include asking the woman whether she is pregnant. If she is pregnant, the live vaccine should not be given. Asking the woman could become pregnant in the next 4 weeks. If she is planning her pregnancy in the next 4 weeks, she should not be given the live vaccine. Counseling her about the potential risks of vaccination during pregnancy or just before the conception. No routine testing for pregnancy is indicated in these women. If the history is consistent that she is not pregnant, no need to do pregnancy test before giving a live vaccines. So, if these vaccines are safe, there is no evidence of harm to pregnant women or fetuses from administration of inactivated vaccines. So, inactivated vaccines can be safely given. Whereas live vaccines which are safe in children and adults may be harmful to developing fetus and should be generally be avoided during pregnancy. So live vaccine should be generally avoided during pregnancy. Vaccines can augment an individual immune status. All but the live vaccines are generally considered safe for administering to pregnant women. So live vaccine should be avoided during pregnancy. Then the timing. When the vaccine should be given in pregnancy, whether it is in first trimester, second trimester, third trimester. Usually we will avoid in the first trimester, but in any gestation age, it can be given. For example, influenza, pregnancy is an high risk factor for influenza or COVID, during which it can be given even in the first trimester. But it is better to delay till second trimester because entire arm is not ruled out with the vaccine if you are giving in the second trimester, but it will avoid the spurious association. The patient may have mental feeling that miscarriage has occurred because of the vaccine, birth defect has occurred because of the vaccine. So delayed until second trimester will avoid all these. Between 28 to 32 weeks of gestation, it will optimize the transfer of antibodies to fetus. So between 28 to 32 weeks, if we give vaccine, within 4 weeks, the maximum immunoglobulins will be reached and that will reach the fetus and that will protect the fetus. So if a no termination of pregnancy is necessary if a live virus vaccine is inadvertently given to pregnant women. Even if a rubella vaccine is given during pregnancy unknowingly, there is no reported reports of congenital rubella syndrome in the because of vaccine. So if a live virus vaccine is inadvertently given to pregnant women, you need not terminate the pregnancy. If a woman becomes pregnant within 4 weeks after vaccination and counsel about the potential effects on the fetus, termination of pregnancy is not warranted for this indication given the absence of documented harm. Immunogenicity and placental transfer. The next question is whether the vaccine given in pregnancy will have same immunogenicity as that of non-pregnant. So immunogenicity in pregnant women is equal to non-pregnant women. Then transplacental passage of antibodies depends upon the maternal concentration of immunoglobulin, what are the antibody types, and what is the gestational age. So fetal IgG concentration, it is much lower than the maternal concentration in first half of the pregnancy, increases to 50% of maternal levels at 28 to 32 weeks of gestation, equals maternal levels by 36 weeks of gestation. It will even often exceeds the maternal levels at term. So this knowledge we should know when giving some vaccine. For example, because the maternal IgG level reaches their peak about 4 weeks after immunization, the gestational age at maternal immunization is an important factor when passive neonatal immunity is the goal. For example, Pertissis vaccine. In the Pertissis vaccine, particularly if you give near term, that is 4 weeks before the term, the maximum immunoglobulins will be reached and that will reach the fetus. So in these cases, the ideal timing of vaccination is in the early third trimester to achieve maximum maternal antibody level and maximum antibody transfer before delivery. So there are some modulators of maternal to child transfer. If there is HIV and malaria infection, the maternal to child transfer will be impaired. If there is a very high maternal IgG, because of the super concentration, it may not be transferred to baby. So then form, we should scrub them. So only vaccines and giving injections and all those things will not prevent the disease. So we should scrub the germs, avoid travel to high-risk location. For example, areas where yellow fever is prevalent, immunize the family, maintain the good hygienic practice like hand washing, using clean water and cooking. Now I will come to the topic proper that is given to me, that is Pertissis and Rubella. So in this figure, an injection is given to the mother to protect the baby from the pertussis. So is maternal vaccination necessary for protecting the baby against pertussis? Yes, it is. That means a maternal immunization with Tdap vaccine will prevent the baby from pertussis, because case fatality rate in infant is very high. There is no immunity at birth and there is no vaccines available at birth to protect from pertussis. So even though pertussis has decreased, there is a resurgence of pertussis in 2010. There were 10,000 to 50,000 cases of pertussis each year are reported, and in 2012, CDC saw that most cases in the 60 years. There were 48,000 reported cases of pertussis, 2,200 of these are infant, and 15 of those infants died. That means it is alarming. Pertussis is increasing. So there is need for vaccination. The pertussis can affect not only the children, it can affect the adolescent and adults, including the pregnant women. But the complications that are seen in adolescent and adults are less than that of children. Even the cough itself can cause the complications like urinary incontinence, syncope, rib fracture in children. So people of all age needs whooping cough. In children, whole cell vaccine Tdap is given. In adolescent, Tdap is given. In pregnancy, Tdap is given. Tdap can be given safely in pregnancy. Tdap is tetanus, diphtheria, and pertussis vaccine combination. So, seriousness of pertussis mother and infant. Pertussis can cause serious and sometimes life-threatening complication in infant, especially within the first 6 months of life. In infants younger than 1 year of age who get pertussis, about half need treatment in the hospital. The younger the infant, the more likely they will need treatment in the hospital. Of those infants who are hospitalized with pertussis, about 61% will experience apnea, 23% will develop pneumonia, and 1% will die. Most pertussis deaths are infants who are too young to be protected by childhood pertussis vaccine. So there is a seriousness of pertussis mother and infant, and immunization in mother can prevent all these complications. So there are no pertussis vaccines licensed or recommended for newborn at birth. That is, in 6 weeks, the vaccine will be given, and it takes 6 weeks for the antibody to develop. That means till 12 weeks of gestation, baby is not protected with pertussis. The best way to prevent pertussis in a young infant is antenatal vaccination. If you give vaccination to mother, it will protect the baby. And cocooning and administering the childhood Tdap series on schedule of 6 weeks. So don't risk spreading whooping cough to your infant. Create a circle of protection. Get vaccinated. Cocooning. That means adolescent adults, parents, siblings, grandparents, child care provider, and healthcare personnel we have to anticipate having close contact with an infant age less than 12 months should receive a single dose Tdap to protect against pertussis if they are not previously received the Tdap. So pertussis vaccine is always available in combination with diphtheria and tetanus. And initially in 1948, diphtheria, tetanus, and pertussis wholesale vaccine was available. That is used in National Immunization Schedule for children. Then Tdap was Infernix Exa, and recently Tdap Boostrix is introduced. So this chart shows the side effects of wholesale pertussis vaccines against the acellular pertussis vaccines. Emergency department visits, life-threatening reaction, hospitalization, disability, death. Everything is more with wholesale vaccine compared to acellular pertussis vaccine. Acellular pertussis vaccines are therefore they are very safe vaccines. So in Japan, after the introduction of pertussis vaccine, the cases have reduced from 1 lakh to almost 200, less than 200. So there was a decrease in the pertussis trend, but the vaccine-related adverse reactions are more because of the older formulation of pertussis vaccine. This resulted in increase in the pertussis because of the immunization schedule was not properly maintained. But with the introduction of acellular Tdap vaccine, it has again reduced. That means a new type of acellular pertussis vaccine is available, and that is combined with diphtheria, tetanus, toxoid, and was introduced, and therefore it has decreased the number of cases. So one recent study found that only 37% of the pregnant women had anti-pertussis antibodies. With a single dose of Tdap, this figure rose to 90%. Almost 95% of the newborn were with antibodies in immunized mother. That means it tells the effectiveness of this vaccine. So maternal vaccination is effective. Presumed protective levels are maintained in 66% of babies at the age of 2 months. Vaccinating pregnant women appears to be the effective and safe intervention for protecting young infants. So pertussis, so when to vaccinate is the question. Is it in the early trimester, second trimester, third trimester? Pertussis antibodies reach a peak 2 weeks after vaccination and decline thereafter. Women vaccinated with Tdap early in pregnancy do not transfer adequate level of pertussis antibodies to their babies. So what is the right time for vaccinating a pregnant woman with the Tdap vaccine? Vaccination in the third trimester is recommended, that is 27 to 36 weeks. This will optimize the antibody transfer, which mainly occurs between the weeks 36 to 40 weeks of gestation, and provide protection to the baby till primary DTP series is given and takes the effect. Maternal vaccination was seen to protect babies against pertussis in the UK, where vaccine coverage among pregnant women was 64%. So if you give Tdap vaccine to a pregnant woman in the last trimester, it will definitely prevent the pertussis in the baby. So this chart shows the effectiveness of anti-pertussis antibodies in bacterial pathogenesis neutralization, emphasizing the importance of placental transfer and breastfeeding. Even breastfeeding will protect the baby in an immunized mother from the pertussis. So premature babies, since the babies will receive very little transfer or very little placental transfer. So it is not known what effect transplacentally acquired antibodies will have on the development of immunity in response to primary TTP series. WHO also recommends that vaccination of pregnant women is likely to be the most cost-effective additional strategy for preventing disease in infants too young to be vaccinated and appears to be more effective and favorable than cocooning. National program may consider vaccination of pregnant women with 1 dose of Tdap in the second or third trimester and at least 15 days before the end of pregnancy. So even WHO recommends the Tdap vaccination in a pregnant woman. So my take-home message is tetanus, diphtheria, acellular pertussis vaccine, that is Tdap vaccination, can be considered instead of second dose of tetanus toxoid to offer protection against diphtheria and pertussis in addition to tetanus. If the regular pertussis vaccine, that is whole cell vaccine, is contraindicated in pregnancy. If the Tdap is not available, even TD vaccine can be given to pregnant women to protect against diphtheria, because even the diphtheria is on the rise nowadays. So my take-home message is pertussis vaccination in mother will protect the babies from the pertussis. There is no other alternative way to treat the infants other than hospitalization. So we should go for Tdap vaccination in a pregnant woman. So my next topic is rubella. Rationale for rubella vaccination context. Immunization programs worldwide have made major impact in the epidemiology of rubella, both in developed and several developing countries. In the US, total cases decreased from 58 per 1 lakh population in 1969 to 0.5 cases per 1 lakh population in 1983 as a result of effective MMR vaccination, and the rubella is almost eradicated. In a study from our own India, Vellore, it is reported that congenital rubella constitute about 10% of all children born there with suspected congenital infection. So in study from Vellore, it is reported that congenital rubella constitute 10% of all children suspected with a congenital infection. So the whole world, if we see, 1 million children are estimated to be born with congenital rubella syndrome each year in the developing world. So rubella is a major problem even in the world. US and UK, rubella has been eradicated since the introduction of MMR vaccine in the 1980s. Versus India, there is no authentic figures on the rubella burden in the community. So rubella, it's also known as German measles. Unimmunized pregnant women contract rubella through nose and throat. If the infection occurs in the first trimester, then definitely it gives birth to baby with congenital rubella syndrome. That is, if the infection occurs within 12 weeks to the mother, there is 85% chances that the baby will get the congenital rubella syndrome. So the congenital rubella syndrome will have abnormalities in the eye in the form of congenital cataract, sensory neural deafness, brain defect, cerebral palsy, learning disabilities, glaucoma, hypertension, cataract, enlarged liver and spleen, etc. 85% of the 100 babies born to mother with rubella will have this disease. The only way to protect this is immunize all the women in reproductive age with rubella vaccine. So immunize all the women with this vaccine. That is, all school-going children should be immunized with rubella vaccine so that we can avoid rubella in the pregnant women in future. The one more thing is, even though rubella is a live vaccine, if inadvertently given in pregnancy, you need not terminate a pregnancy because there is no congenital rubella syndrome reported because of vaccine. Whereas the infection will give to congenital rubella, but vaccination will not given. But however, women should be informed that if they take rubella, they should avoid pregnancy for at least 3 months. So preconceptionally, rubella vaccine, hepatitis vaccine, varicella vaccine, that is live vaccine should be given preconceptionally. Antenatally, TT should be given, TD should be given, Tdap should be given. Influenza and hepatitis B can be given throughout, and postnatally we can sensitize the women about the vaccination. We can give TT, Tdap, influenza, and hepatitis B virus. So don't forget, I am giving you some important points to you. The clinician should be well informed about the correct dosage of the vaccine, storage recommendation for the vaccine, contraindications to vaccine, and adverse reaction of all vaccine. And whenever you encounter these diseases like pertussis or rubella and other, they are notifiable disease. Whenever these infections are identified, the appropriate authority in your locality should be informed about the disease. And the vaccine should be stored between 2 to 8 degrees centigrade at all times. Vaccine should be placed on the middle shelves of the refrigerator. Influenza vaccine should never be exposed to freezing temperature. Vaccine effectiveness can be decreased by exposure to light. So my take-home message is improving the immunization rates, improve the communication with your patients. Take time to listen. 84% of the parents of opinion, doctors are the main source of information about vaccine. That is, if the doctor tells about the vaccine, they will be sensitized and they will get the vaccine. Otherwise, they will not get the vaccine. So whenever a patient or parents are in contact with you, take time to listen, solicit and welcome questions, keep conversation going on. My take-home message is that education regarding vaccination is more important than education regarding the disease. Thank you. Thank you for the opportunity to share my knowledge.
Thank you, sir. I request Dr. Preetham ma'am to kindly give concluding remarks for Dr. Shivakumar's speech.
Thank you, Dr. Shivakumar, for nicely briefing about the vaccination during the antenatal period. As we all know, our infants during early age, up to 2 to 3 months, they don't have enough immunity, and they are exposed and to these diseases, especially diphtheria, pertussis, and tetanus. So antenatal period and immunizing pregnant women during antenatal period is very, very important to save our children, save our infants. But still, unfortunately, we don't have that clear guidelines from the government, and it is not included. DPT, Boostrix or Tdap is not included in government's guideline. So most of the, even in our scenario, in our place, most of the gynecologists are still, even not the gynae practitioners, those who are not with the degree, those who are MBBS or general practitioners, they are not promoting, and even gynecologists, most of the gynecologists are not prescribing Boostrix at our places. So awareness has to be there, and more of the government contribution should be there, so that the vaccination improves in antenatal period. Though there is a lot of tetanus immunization, maybe some patients are taking twice, thrice, some are taking it 6 weeks, some are taking it 18 weeks. We don't know. So uncontrolled vaccination for tetanus is there, but not TD and not Tdap. So that has to be, knowledge has to be imparted to even doctors. Say what to say about the people. People will only gain knowledge if the doctors are imparting on that, or medical professionals, or the workers, nursing staff, and those who are providing vaccination in the periphery. If they directly communicate to the patient, that will come to the patient's mind, and they will ask for these vaccinations that I should get. Only the literate pregnant females are like, even literate females, if we prescribe Boostrix, they will ask this and that and 100 questions. So we'll have to answer them. Definitely, we should all do our best efforts to improve the outcome. Thank you again. Thank you, Dr. Shiva.
Yes, ma'am. Actually, government policies and providing free takes long time, madam. Education regarding vaccination is very important. That's why what we are doing in Ballari OBG Society is we have taken cervical cancer eradication as the main program. So we
Yeah.
are conducting a school health program. We are educating from our society in each taluk. A doctor is going and we have selected the school and allotted the school. They will go and telling about the Hpv vaccination there, so that school children will spread to other, so that we can at least reduce some even 3 or 5% of the
definitely.
cervical cancer. It is worth. So Jamunat Gowda sir and Usharani madam and I myself are working on it, madam. We
Yeah.
are conducting school health
Yeah, that's
education
good.
program.
That's good.
So thank you, sir.
Thank you, madam. Thank you.
And I welcome Dr. P.V. Hanmantrao, sir, our chairperson for the session Vaccination in Women. Dr. P.V. Hanmantrao, sir, MBBS, DCO and Diploma Diabetology, and President AP Nursing Home Association Guntur, and Treasurer of APCOG 2019, Consultant OBG and diabetologist practicing for 40 years at Sri Venkateswara Nursing Home, Guntur. So kindly speak a few words and introduce Dr. Sangamesh sir.
Good evening, everybody. Thank you for introducing me. And I want to introduce Dr. Sangamesh S. Matapti, MBBS DGO MS OBG, and he is trained in basic and laparoscopic, advanced laparoscopy, and his present designation is Associated Professor, Department of OBG at Sri B.M. Patil Medical College and Hospital, Bijapur, Karnataka. And his research work is a sub-investigator in various international research projects funded by WHO and GN. And his areas of interest are high-risk pregnancy, infertility, and laparoscopy. His publications, various publications in various national and international projects. I welcome Dr. Sangamesh to talk on vaccination in women. Thank you.
Good evening, everyone. I hope I'm audible to you. Okay, at the outset, I thank the Andhra Pradesh OBG Society for providing me an opportunity to interact with these eminent people and share my knowledge regarding vaccination in women. So far, Shukumar sir has already discussed about the rubella as well as the Tdap vaccines. We'll be just giving an overview. As all discussed, there is no universal protocol or the guidelines for the government of India regarding vaccination in women. There are universal immunization program for the pediatric age group, but not for the adults in India, especially for the women. So I just gone through the various guidelines available. The FOXI committee has recommended certain guidelines for the vaccination for women in India, and also the American Society of Obstetrics and Gynecology. So considering those things, I would like to share the things what we have understood so far. Well, to start with, Wikipedia says a vaccine is a biological preparation that provides active acquired immunity to a particular infectious disease. We usually think vaccination is meant only for the pediatric age group, or for the pediatrician is responsible for that, and the physicians are responsible for those a special category of people who need vaccination in adulthood or they're in the elderly age group. But we see that a woman crosses through various phases, putting herself into a special category compared to a man in various in her lifetime, like adolescence, preconceptional period when she is about to conceive, during her pregnancy, which is a special case, carrying another life inside a womb. So we as physicians play a vital role in giving vaccination services, educating a lady and her family regarding the vaccinations available and the health benefits of those vaccinations. Now let me discuss just a brief about what are the possible stages, and what are the possible vaccinations we should offer. Adolescence is a catch-up phase. Like we all know that the universal immunization schedule has been put up where they start vaccination from birth to around adolescence, 11, 12 years, the pediatricians will be taking care of. If certain, by chance, which is very common in Indian setup, if a woman misses or a child misses the vaccinations, we consider this adolescent as a ideal time to give a catch-up vaccinations, especially for hepatitis B, tetanus, diphtheria, that is Tdap, typhoid and influenza in seasonal cases. Rubella vaccination, as sir said, already discussed about these things. We just want to say that we don't need to have testing for a rubella, whether she's already exposed or not. Empirically, we can provide rubella vaccination for all the adolescents to protect her reproductive life in the future. But as sir said, we should avoid pregnancy for the next 3 months once she is vaccinated. If by chance she conceives post-vaccination, that is within 4 weeks of vaccination, yes, it's a concern, but need not warrant for termination of pregnancy. We just need to serially monitor. There's very, very less chances of having a rubella-related syndrome. HPV, yes, this is the main vaccine which we want to target the adolescents for prevention of cervical cancer in her future life. We come to preconception, like a woman newly married and about to have started her family, we will she'll be our target for the rubella vaccine if she has not received. Hepatitis B, varicella vaccination should be given. All these vaccines we should try to give post-menstrual period, just to make sure that she is not conceived in this previous cycle. If we provide, consider this time and provide the vaccination, it will be a little safer. If by chance she receives a vaccination and she is conceives, this is safe. Like the hepatitis B vaccination has been given as a prophylaxis for some reason and she conceives, it is safe to continue the pregnancy. There is no need to terminate the pregnancy. HPV vaccinations can be considered in this age group, but as we said, if she conceives after the first dose, no need of termination of the pregnancy. The rest of the schedule has to be continued once her pregnancy is completed. Now, coming to the special category, what we face, it's pregnancy. It's a conventional teaching. We've been studied that a pregnant woman should receive 2 doses of tetanus toxoid 20 days apart, preferably after the second trimester. But now, as sir has already discussed, the Tdap has come, which has enlightened us that there is scope for adding a pertussis component or for giving an extra edge to the to-be-born baby of the mother. So Tdap vaccine has to be considered whenever we get an opportunity. Most of the times they receive 1 TT dose and they come to us, we should give Tdap. If we don't have a Tdap vaccine, we can just give TD vaccine, which is just a combination of tetanus and diphtheria without a cellular pertussis. The IAP actually suggests immunization of pregnant women with a single dose of Tdap during the 27 and 36, as sir said, regardless of the interval between the previous vaccination, just to protect the to-be-born baby. Influenza vaccination is recommended basically beyond 26 weeks of pregnancy, but in case of a pandemic, as recently we have faced the pandemic of COVID, if there is any pandemic in the zone, we can give it an earlier dose safely. Now, considering the post-reproductive age group, a woman has got to go through her perimenopausal, postmenopausal period. So even then, just like any other general population, we'll be considering her for tetanus booster dose to be given once in every 10 years throughout her life. TD can be given throughout in case of just simple giving tetanus toxoid injection. HPV vaccination is licensed only up to the 45 years of age because of the age considerations. The high-risk age group will be passed. And if unvaccinated adults of age group of 65 or older are to be vaccinated, we give them Tdap and tetanus toxoid because it also provides additional protection to the infant who are under the care of these elderly females in the family. So it will add to an additional protection. So we have seen so far the general guidelines by the FOXI, which recommends for the most of the special categories or the zones or phases of life of a woman where we have to consult for vaccine. Just let us go for the individual vaccines. This is the recommendations of the FOXI for all the vaccines in the particular age groups. Coming to the most discussed topic, that is HPV vaccine. It's an inactivated vaccine. What we usually want to give this is to not only prevent CS cervix, we want to give it to prevent CS cervix, vulva, oropharyngeal carcinomas, wherever the possible HPV vaccine can affect and cause a malignancy. It gives protection. So we are using this vaccine to prevent that. Also, not only females, we can use it in boys for genital warts and penile and anal lesions. Now, what is our target group? We preferred, it's preferred is 9 to 14 years of age, but it can be given up to 45 years, as I already told. The number of doses are less than 15 years and non-immunocompromised patients, like girls, will be 2 doses. More than 15 plus or immunocompromised, the doses will be 3. These are the brands which are available. In India, we have Cervarix and Gardasil. Gardasil 9 is yet to be marketed in India. Usually, it will be stored at a 2 to 8 degrees centigrade. As we all know, popularly the Cervarix has a bivalent and Gardasil has a quadrivalent vaccine. 0.5 ml of IM injections to be given. The new one, the Gardasil 9, is yet to be marketed. It has got a 9 protection against the 9 variants of HPV. Usually 0 to 6 months is the interval between the 2 doses. And then we have bivalent 0-1-6 or quadrivalent 0-6. The catch-up vaccine, like when we didn't get the candidate at the appropriate age, that is 9 to 14 years, we can still give it at 15 to 16. It is usually 3 doses. And we should want the female that she might be already exposed to the HPV vaccine virus. So the routine screening has to be continued apart from taking the vaccination. It is not, the vaccination doesn't prevent the infection, it prevents the cancer.
We will utilize this time. There is a small video that I'm sharing. After that, I'd like to address the gathering.
Jagsonpal Pharmaceuticals Ltd proudly presents Pro Retro Micronized Dydrogesterone Tablet 10 mg. Jagsonpal is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for Pro Retro.
A very good evening, all esteemed faculties and our attending doctors. I am Ram Kumar, Zonal Manager, South India, taking care of NARI, a division of Jagsonpal Pharmacological Ltd. Doctor is seeking your help for support for the Pro Retro, for lethal phase support in ART, recurrence, pregnancy loss, and in threatened abortions also. We thank you all for this opportunity to connect through this webinar today. And to present Pro Retro 10 mg micronized dydrogesterone tablet. We take immense pride in sharing that with years of R&D in Jagsonpal Pharmacological Ltd has been successful in manufacturing high quality API for micronized dydrogesterone with all the intermediates in our GMP certified manufacturing facility. So the quality of our brand Pro Retro is backed by the bioequivalence study to prove its clinical efficacy and safety with these clinical advantages of a Pro Retro is capable of assisting motherhood, delivering happiness. So our indigenous API of Pro Retro offers a remarkable reduction in the cost to the patients, providing a more economical therapy of just 50 rupees per tablet to the patient. Pro Retro is readily available in all pharmacies nearby you. Looking forward to your support to Pro Retro. In the newest brand in our product portfolio comprising Endorec and Cystelia-M. So thank you for your presence today, and we look forward in coming further webinars also. Thank you very much, Doctor.
This is the next webinar which is coming up on Thursday, 9th of March. The webinar ID is mentioned over here, which can be taken down. You can register now only for this webinar which is coming up on adolescent health. Thank you very much, Mr. Ramkumar. Thank you, everybody, sir.
Thank you. Thank you, Umasangar, sir, for this opportunity, sir.
Yeah, we were discussing about the hepatitis HPV vaccine. Yes, the special considerations, if you have missed the dose, yes, we can catch up at any time. and continue up to 45 years of age. Pregnancy is a contraindication. If adherently given, as I said, we can continue the pregnancy. Lactation, yes, we can give. And women with abnormal screening, we can just continue as any other female without any abnormality. It's absolutely fine to continue. Okay, these are the brands which are available in India with the cost, Cervarix and Gardasil. This is an approximate cost for this. Now, the routine side effects we're expecting from with these vaccines, syncopal attacks, pain, nausea, headache. When it was initially launched, there were some reports of deaths, but they were all accidental and incidental deaths, nothing related to the vaccines which was ruled. So safely all the adolescents and the eligible candidates can be immunized using this available HPV vaccines and protect them from malignancy of cervix and various other conditions. Now the COVID vaccine, which is the hot topic now, we all gone through the pains because of this COVID pandemic, and we should congratulate our team of doctors who so quickly developed these vaccines. We have Covaxin, which is a whole virus vaccine killed one, which is by Bharat Biotech, and Covishield, which is a viral vector vaccine. And Pfizer and many companies are coming up with the vaccines. Like in women, like it's approved over 18 years of age in all the like males and females. Women can receive vaccine even during menstruation. There are so many myths about this COVID vaccine. People will call and ask, can we take today, tomorrow, like I'm menstruating, I'm about to conceive, I'm pregnant, and all those things. So we can say safely so far now that we can take during pregnancy, during lactation, and there's no need of testing for the pregnancy before giving vaccination. If already infected with COVID in the past, vaccine should be deferred for 12 weeks from the infection or 4 to 8 weeks from the recovery. Yes, for the immunity issues, it can be given with high-risk pregnancy also. The contraindication is, as usual, anaphylactic allergic reactions, immediate or delayed onset anaphylaxis for the components. We can temporarily suspend if she has suspicious of COVID-19 infections or she is acutely unwell and has been hospitalized. We avoid. The TD vaccine and all already sir has discussed. Just to mention, we prefer nowadays Tdap vaccine compared to the TD vaccine, tetanus vaccine. And Tdap, as we say, the 27 to 36 weeks is the period when we prefer to give the TDP vaccine. Okay. Now, this is the available vaccines in India. Routine side effects. Now coming to varicella chickenpox virus, we have a single antigen varicella vaccine which is subcutaneous, or we are a part of MMR. MMR already sir has discussed about this. We recommend 2 doses of vaccinations. Usually it is given from 12th to 15th month of life. A second dose 4 to 6 years of life. Adolescents of 13 and plus, we give them at 4 weeks apart, 2 doses as a single dose or as with the MMR vaccine. The varicella vaccination is also recommended in a post-exposure prophylaxis. When the woman is exposed to the varicella infected people, then it is better to give within 3 to 5 days of exposure. Then it gives 170 to 100% effectiveness from acquiring the chickenpox. Now, the contraindication, as usual, for the severe allergic reactions to the components, immunocompromised states, HIV infection, or hematopoietic cell transplant, and as usual, a pregnancy. As I said, pregnancy, we should avoid all the liability vaccines. These are the routine side effects and the brands available in India. Influenza vaccine, as we discussed already, beyond 26 weeks, it is recommended in pregnancy. We have trivalent vaccines containing type A, type B, and type C, available in 2 forms. One is inactivated and one is live attenuated vaccines. Yes, live attenuated vaccines, as usual, is avoided in pregnancy, in children less than 2 years or adults above 50 years, and usually with immunosuppression. The recommendations are 6 months to 5 years, and usually chronic medical conditions, adults who are at risk of infection, like the constant travelers who are going to get exposed to the various international population, so them better to receive this vaccination. Now, contraindications, as usual, it is the persons who had severe reaction to initial dosage or persons having health allergy. We better avoid this. The brands available and the costs for the in India are these are the things. Now, just to complete the vaccination protocol, like for the adults or a special category females, we have pneumococcal vaccines. Aged more than 65 years, splenectomized patients or immunocompromised patients, or patients with CSF leak, chronic medical conditions, usually administered in the form of intramuscular or subcutaneous injections. The PCV13 is an intramuscular injection, or PPSV23 is given both intramuscular and subcutaneous routes. One dose for all the adults between 19 to 65 years old. Schedules varies according to the medical conditions where it is indicated. Now, these are the schedules which we have for the PCV13 and the PPSV23 for the various conditions. Contraindications and precautions are all for the as usual for any other vaccination. This is the brands available with the cost in India. Now, hepatitis B, yes, hepatitis B indications for as in any adult, we can give it to from 19 years to onwards. If it can be used as a catch-up condition where previously the lady has been not immunized during her childhood. We can give whenever it is warranted. What are the indications? These are the available vaccines. One is a monovalent, that is recommended DNA hepatitis B vaccine. Another one is a Twinrix, which is a combination of B and hepatitis B virus. When to use? At risk of getting exposed through sexual partners or polygamy or household contacts, like any elderly person or any person who is HBCG positive in the family members, and the lady is exposed to that person, we warrant hepatitis B immunization in this lady. These are the other medical conditions like end-stage renal diseases and HIV infections. We prefer them to go for hepatitis B infection. These are the available brands in India. Just to complete, a meningococcal vaccine, it's available in quadrivalent. For conjugate vaccines, and group B meningococcal vaccines are available. Recommended in persons with persistent complement component deficiencies, persons who have functional or anatomic asplenia, including sickle cell disease, or in HIV positive patients. Microbiologists who are readily exposed to Neisseria meningitidis, and public health officials, persons who travel from country to country. Yes, we recommend them with the meningococcal vaccines. The schedule is one dose at 11 to 12 years, booster at the 16. Okay, sorry, this is the graphical representation of all the vaccines in the females from adolescence to menopause. Sorry for the technical hiccup. I just want to conclude that vaccination should be offered to all women throughout their life, because one or the other vaccine fits at the various phases of their life. The clinician should be well informed about the correct dosage, recommendations, the contraindications, adverse reactions of all those possible vaccinations in females, so that they give a better picture and gain the confidence of females to get protected by taking these vaccinations. I once again thank the Andhra Pradesh OBG Society, Rajasthan OBG Society, and all Karnataka OBG Society, which brought me to the platform where my teachers are providing the guest lectures. Thank you. It meant a lot to me. Thank you. Thank you, Ananda.
Thank you, sir. I request Dr. Hanmantrao sir to give an expert opinion on Dr. Sangesh sir's.
Vaccination is the best prevention against complication of diseases. Vaccination against possible infections at various stages in a woman in life is very crucial. It's a very important topic, relevant, and it's extensively covered. Thank you, Dr. Sangesh.
Thank you, sir.
Thank you.
Thank you. Thank you both. And she's the HOD and Senior Consultant, Dutch Hospital, Alwar. She has received awards for Ma'am Award for excellence in academics and working for public awareness in breast cancer and menstrual hygiene in association with NGO Inner Wheel and Rotary. And her publications includes Foxy Editor, Newsletter Alwar, and her special interest in high-risk pregnancy and pregnancy with medical complications. I request you to speak a few words on miscarriages after IVF and eventual success, and introduce Dr. Harsha Madam.
Good evening, everyone. Thank you very much for making me a part of this academic bonanza. Today, we are discussing on many aspects in the pregnancy, but most important questions, what is frequently asked by the patient is what will happen after the miscarriages, especially in IVF pregnancy, and what are the eventual success rate. And today, we are going to discuss on this point our eminent doctor, young dynamic, Dr. Sri Harsha Rawuri, who has done fellowship in reproductive medicine from Guntur. She is working in Guntur, is talking on this topic. She is a well-renowned doctor. She has presented in many international conferences. She has spoken on receptors polymorphism and role of aspirin in SCH in infertility patients. She is a bright student. She cleared all the exams with flying colors, received gold medalist in many times in graduation and post-graduation. She attended actively in UVA Foxy at YZEC and UVA ISAR. She has attended many state conferences and presented n number of papers. I invite Dr. Sri Harsha Rawuri to speak on this topic. Thank you.
Thank you, Monica ma'am, for that kind introduction. I would like to thank APOGS Society, the office bearers, Dr. Uma Shankar sir, Dr. Venkatesh Garu, and also Dr. Hanumantrao sir, who have given me this opportunity. And also I would like to extend my regards and best wishes to the OG societies of Bijapur, Bellary, Ajmer and Alwar. Thank you. Is my screen shared? Can I talk?
Yes, ma'am.
So today I'm going to talk about the miscarriages after IVF and the chances of eventual success. So for many, the miscarriage is a part of the fertility journey. Miscarriage can be a devastating loss for women, that too after undergoing an emotional and time-driven journey, particularly in the IVF patient, for the IVF patients. This miscarriage can be a devastating loss for women, their partners, as well as their families. Therefore, it is very essential to provide a consistent and evidence-based approach to the diagnostic test, the treatment options, and the supportive care to increase their chances of a successful birth in future. A ray of light is a significant proportion of cases of recurrent miscarriage remain unexplained despite a detailed investigation. So these women and their partners can be reassured that the prognosis for a successful future pregnancy with supportive care alone is around 75%. With this introduction, we all know that the most important question which the couples of facing miscarriage would ask us is, what is the chance of future successful pregnancy after a miscarriage? So even when etiological mechanisms are not fully elucidated, well-developed and validated prediction models may provide the adequate estimates of the future pregnancy outcomes. My talk today would be covering about the causes of miscarriages in brief, and also about the causes of miscarriages pertaining to IVF in particular, and discussion about the prediction models, and Finally, about the interventions to improve the chances of eventual success. We all know that miscarriage is loss of pregnancy before the fetus reaches the viability age, that is around 20 weeks. And the prevalence of the miscarriages actually can be classified according to the type of miscarriages. The sporadic one, which is around 25% of the pregnancy losses, that is the sporadic miscarriages constitute about 25% of the pregnancy losses. And a woman may have about around three sporadic pregnancy losses during her obstetric career. The other condition is the recurrent pregnancy loss, which is defined by various societies. According to the current guidelines, it is around it is equal to or more than 2 pregnancy losses, which could be consecutive or non-consecutive. So recurrent pregnancy loss ranks among the most distressing conditions in reproductive medicine, which affects around 1 to 3% of the couples. So having classified into sporadic and recurrent, if you're going into the causes, the most common cause for the sporadic miscarriage is obviously the genetic problem, the chromosomal abnormalities in the fetuses. Still, most of the causes, in most of the cases of sporadic miscarriages, still the cause remains unexplained. And we all know that our reproductive efficiency is very, very meager, because only 30% of the conceptions reach to the live birth. The other 70% conceptions do miscarry. That too, 60%, they undergo preclinical loss even before implantation, that is 30%, and after implantation, before the woman misses a period, that is post-implantation, another 30%. So the miscarriages can be classified as preclinical, and when concerned to clinical, it is again early, which is less than 10 to 12 weeks, and late after 12 weeks. So if we are thinking about the causes of miscarriage, miscarriages, either sporadic or recurrent, sometimes they are, of course, most of the times they are overlapped. Most common causes of the sporadic miscarriage are also causing the recurrent miscarriage. So we can commonly look into the causes for the miscarriage and discuss about them. If you're looking into the miscarriages, particularly recurrent miscarriages, the most common and the most important bulk of the miscarriages is formed by the unexplained miscarriages, which includes the non-antiphospholipid antibody syndrome thrombophilias, followed by the most important cause, that is autoimmune thrombophilias like antiphospholipid antibody syndrome or SLE or any other autoimmune diseases, followed by the endocrinological causes, which may include diabetes, which may include hyperprolactinemia, which may include any thyroid abnormalities. And the next important cause could be the anatomical causes, which constitute around 10 to 20%, which include the uterine abnormalities. Sometimes uterine abnormalities, uterine anomalies are associated with even the cervical insufficiency or cervical incompetence. And all these causes form the anatomical problems. Also, sometimes the fibroids, submucous fibroids could be one of the cause for the recurrent miscarriages. In addition to the cervical T-shaped uterus, uterine synechiae and polyps, all these form the important causes for the anatomical abnormalities, which could be the cause of recurrent miscarriages sometimes. So the other important causes, the next to these causes would include the genetic issues followed by the infections. Genetic issues, when we are discussing, it could be either sporadic or recurrent miscarriages. Usually the sporadic causes for the pregnancy losses would be mainly due to aneuploidies in the fetus or in the embryo. Mostly when there is aneuploidy in the fetus, the parental karyotyping would be normal, as this is a sporadic event. This is due to the defective gametogenesis, and in such cases evaluation of the parental karyotyping is not actually required. And also the chances of having successful pregnancy in the successive pregnancies is more than 70%. Also, if we are looking into the causes of the recurrent miscarriage with genetic association, we can look into the causes of like translocations, either balanced or unbalanced in the parents. Usually the balanced translocations in the parents lead to the unbalanced translocations in the offspring, which lead to the miscarriages. Also, deletions, duplications, and dicentric and ring chromosomes are few causes for the abnormal reproductive outcome. So having enumerated the causes, the most important thing which also has to be borne in our mind is to consider about the semen factors, especially when we are considering about the severe oligoasthenoteratospermic samples. We have to look into the sperm DNA integrity, which actually is the functional measure for the sperm quality. Our semen analysis, which we are doing currently, the routine semen analysis, will not tell about the functional capacity of the sperms. There are certain special tests to know about the functional ability of the sperm, its fertilization potential. So the seminal factors should be borne in mind, and also the lifestyle related one, because smoking, alcohol, and the BMI, all these are found to have association. Extreme BMI or extremely low BMI, both are found to be having associated with the recurrent miscarriages. And there are many good studies and a lot of evidence is coming up on the association, proving the association of these factors with the recurrent pregnancy loss groups. So if we know the risk factors which cause the recurrent miscarriage, it is very easy for us to predict the prognosis, or to understand that this woman has a chance of having repeated miscarriage, or the chances of, or the reasons for the miscarriage could be explained because of these risk factors. So having that in mind, we have to understand about the implantation before we proceed to know about the causes of the unexplained pregnancy losses, because all the causes which have been attributed to the pregnancy loss, like antiphospholipid syndrome, anatomical abnormalities, all these are correctable to major extent, which means the output would be very, very favorable. So, but the important focus of our talk today is to concentrate about the unknown causes, that is the unexplained causes of the pregnancy losses. So to understand that, we need to understand the process of implantation. So implantation is a process which involves the synchronization of the endometrial maturity with the fertilization or with the embryo. So this process of implantation involves two processes. One is the endometrial remodeling or decidualization, which includes the expression of the several molecules and the hormones over the endometrium, which includes estrogen, progesterone, HOX-A10 genes, integrins, which expression of pinopodes over endometrium, and also certain inflammatory mediators like integrins and growth factors. So there is a balance between the inflammatory mediators which are protective and which are destructive or cause the embryolysis. For example, the natural killer cells, their presence in minimal amounts is actually good. But if the balance or if there is increase in the natural killer cells, again, it leads to the failed implantation or the recurrent miscarriage. Similarly, there is a chance that there is a shift of T helper 1 immunity to Th2 cell immunity. So this shift or the balance between these two is disturbed in certain cases. So this has to be borne in mind when we are understanding about how the implantation failure or the pregnancy loss occurs. So to sum up the causes of the unexplained miscarriages, we have to understand that there is defective gametogenesis, which means the oocyte or the sperm are abnormal. Mostly it is sporadic and leading to the abnormal embryo formation and thereby miscarriage. Similarly, there is effective embryogenesis. The causes again would be the same, which have been explained. Again, the third one is the defective implantation, which includes the decidualization, and as well as the second part of this implantation is a placental vascularization. So this part, when it is defective because of the thrombotic events or the infarcts which are due to the certain thrombophilias, there is a chance that the miscarriage occurs. Progesterone has got a very, very important role in the implantation, because it has got two roles. One is to stabilize the blastocyst implantation by maintaining a balance between the pro and anti-inflammatory agents. Especially it maintains the balance of shift between Th1 and Th2 helper cells, and also it also maintains the balance of natural killer cell count, and also it has a very important role to play as an immune modulator. So it is very, very important when we are treating with patients of miscarriage with the progesterone. The pathophysiology has to be understood. So for all the pregnancies, for all the miscarriages, it is not mandatory to supplement with progesterones, and we have to understand that unexplained miscarriages, or in certain cases of where we suspect the corpus luteal deficiency, especially in certain cases of hyperprolactinemia, or in cases of the IVF pregnancies where the corpus luteum is absent in cases of frozen transfers, or in the fresh transfers also the luteal function will be defective. Such cases, definitely progesterone has a role to play. So the other areas where the exogenous progesterone may rescue is in the areas where the luteal phase deficiency occurs. So it's very, very important to understand the importance and role of progesterone and to supplement the patients with this in miscarriages. So when we are talking about the unexplained miscarriages, as I have explained about the abnormal cytokine production, the misbalance between Th1, Th2, lack of integrins, increased TNF alpha and natural killer cell, all these have been proposed to be the causes of the unexplained miscarriages. And also the inherited thrombophilias, which are like protein C, protein S deficiency, factor V Leiden mutation, prothrombin gene mutation, hyperhomocystinemia, all these things have found to be the few causes for unexplained miscarriages. These things are tested. The inherited thrombophilias are tested only when there is a strong family history, or there other causes are ruled out. Other thrombotic causes have been ruled out, but still we are suspecting some coagulation defects. So in such cases, we can test for the hereditary thrombophilias. Otherwise, routine testing is not indicated. So it is very important to remember that in an unselected population of recurrent miscarriage, there is relatively good prognosis of about 60 to 80% for subsequent live births. So, so even when etiological mechanisms are still not elucidated, well-validated models, they provide adequate estimates for the future pregnancy outcomes. There are a lot of prognosticating tools, but ASHRAE proposes Brigham and Lund models, which consider maternal age and number of prior pregnancy losses as a good predictive factors for estimating the success of the future pregnancy in the patients who have suffered with the recurrent pregnancy loss. So the other predictive factors which have to be considered while considering the prognosis or the eventual success rates are prior IVF treatments, uterine factors, autoimmune conditions, sperm factors. Especially, we should never forget about the lifestyle. So here are a few tables where the prognostication about the future pregnancy or the risk for the future miscarriage have been given clearly. A woman who has one live birth with one prior loss is 24% of having miscarriage, and that risk has been increased if the number of miscarriage prior losses are more. Similarly, when there is no live birth, even with 2 miscarriages, the risk is quite high. And again, maternal age. According to with the maternal age, the risk of aneuploidy probably would be increasing, and this could be an indirect cause for the increased miscarriage rate, apart from the addition of the certain increased comorbid conditions with the age. So these are the 2 models proposed and validated by most of the studies, Lund et al. And Brigham. Again, they use maternal age and previous miscarriages. So with all these prognosticating models, we can actually assure the patients with miscarriages, especially the recurrent miscarriages, the chances of their pregnancy is almost up to 60 to 80%, depending on their age and depending on their prior losses. So why are we discussing about the miscarriages in IVF? It is actually proven in many studies that the rate of miscarriages after IVF or infertility treatment is little high. Why it is high? So probably we can attribute all the causes which we have discussed in the previous slides causing miscarriages in IVF too. In addition to them, we can also put up few factors, like all the people who have undergone IVF, most of the people, they come with decreased ovarian reserve. So decreased ovarian reserve usually happens in elderly ladies. And again, the elderly woman will have more incidence of aneuploidies, and probably that could be one of the cause for indirectly for causing more miscarriages. The other most important thing, which is probably the mechanism is not completely explained, is the common etiopathogenesis. Even young women with diminished ovarian reserve, we find there is a good association with the pregnancy loss. This is the most important point. So whenever we're evaluating a patient with a recurrent pregnancy loss, we have to consider their ovarian reserve too. As a reproductive medicine consultant, it is a routine practice for us to look into the reserve and sperm factors. But for a general gynecologist also, it is obviously better to think about the association of the diminished ovarian reserve associated with the pregnancy loss. And also we have to think about the genetic issues and also mitochondrial issues, especially for the aged oocytes. The pregnancy loss rate is quite high, and the structural abnormalities like translocations, all these things in the female itself. So considering the male factor, again, it's very, very important in cases of unexplained pregnancy losses. Most of the times, the DNA integrity of the sperm, the DFI, DNA fragmentation index, which is measured, would be quite high, which means the sperm has undergone oxidative stress and its functional ability is reduced. In such cases, it is better to select a sperm with special methods and allow it for fertilization. So DFI is found to be clearly associated. There are many randomized control trials which support the association of DFI with the pregnancy loss. So again, the sperm aneuploidies, particularly when we look at them, there is a very good evidence about the sperm aneuploidies with the pregnancy loss. Also, again, the balanced translocations in the male partners are definitely a cause for the pregnancy loss, because they cause genetic abnormalities in the fetus. The most important thing which we have to think about the IVF procedure related miscarriages is because of the improper handling of the gametes, the media which we are using, the culture conditions which we are following. These cause abnormal gametogenesis and embryogenesis, which lead to aneuploid embryos. So most of the times, this also after miscarriage, after IVF, after transferring embryos, if the quality of the embryo is not good in spite of not having too many risk factors, or if the output is always the miscarriage, we also should consider about the embryology related conditions. The most important one is the embryo transfer technique, where if we transfer the embryo close to the fundus, sometimes it may lead to ectopic, which is also one of the causes for the pregnancy loss after IVF. Usually these people are associated with the tubal disease, where most of the time the hydrosalpinx is neglected without being treated or without being delinked with the uterus. And sometimes this is the most important cause. Even after transferring good embryo, after a good endometrial preparation, still the implantation will not be proper, or sometimes there is a chance for the miscarriage. So all these things should be borne in mind when we are considering the miscarriages in the IVF, and when we are trying for the next pregnancy, all these conditions should be evaluated and taken care of. So as I said about the diminished ovarian reserve being associated with the pregnancy losses, this is a nice paper, recent systematic review and meta-analysis supporting it. And also the sperm DNA integrity, where the sperm DNA fragmentation is found to be associated clearly with the recurrent pregnancy loss. This is also a very recent systematic review and meta-analysis. So what we have found is that when there is high DFI, they have compared the samples of ejaculated sperms with the testicular sperms. But that means we have taken directly the sperms from the testis itself without taking the ejaculated sperms. The idea behind taking the testicular sperm is that the oxidative stress which the sperms would undergo is far less when compared to that of the ejaculated sperm in the testis, because after moving away from the testis, it has to pass through various paths to get ejaculated. So during this process of passage, the oxidative stress is more, and hence the idea of taking testicular sperms in cases of this semen sample with high DFI is just to have a better sample and better outcome, that is reduced pregnancy losses. So this is one of the most important reason why we do TISA or testicular sperm aspiration, or TZ, for high DFI patients or severe oligoasthenoteratospermia patients. So this is one paper which explains that the fish detects the increased sperm aneuploidy in men with recurrent pregnancy loss. So what to do when there is high DFI? The solution would be ICSI, because the fertilization capacity is low for sperms with high DNA fragmentation index. Apart from, and there is good evidence to support that, apart from ICSI, the sperm selection methods which are commonly used for the selection of good sperms for these patients are microfluidics and magnetic sperm cell sorting, and also IMSI, like morphological sperm selection, which happens with higher magnification, and also hyaluronic acid binding, which is otherwise called as PIXI. All these methods are actually helping in the sperm selection, but microfluidics is observed to be more promising, and still it needs a lot of good trials and good amount of good number of prospective studies are awaited, but still among all these microfluidics stands promising. Right now there is little evidence for its routine use. So as we have discussed about TISA, let's move on to the other important solution, that is pre-implantation genetic testing, which is done after IVF. What is the indication of doing PGTA in ART? So we all know that advanced maternal age is one of the major risk factor for aneuploidies. So in women with advanced maternal age, we can go for PGTA or PGT, pre-implantation genetic testing of aneuploidies. Also in severe maternal male factor, where there is severe oligoasthenoteratospermia, there is associated genetic abnormalities in the sperm. So, and hence we can go for the pre-implantation genetic testing for aneuploidies in such cases in embryo. So the most important topic which we are having interest today is the recurrent miscarriage, where if the couple is having a recurrent miscarriage, but there is no genetic cause which could be detected, that means unexplained recurrent miscarriage or recurrent miscarriage without a genetic cause, there is no routine indication for doing a PGTA. But if these patients are associated with advanced age or severe oligoasthenia, we can go for the PGT. So the crux of this of the discussion is that pre-implantation genetic testing, if we are doing for unexplained cases where parental karyotyping is absolutely normal, in such cases, the pregnancy loss could be sporadic also. So PGT will not actually, definitely PGT is not the only solution, because even with expectant management, after a few pregnancy losses, these patients are going to have a successful normal pregnancy also. So cumulative live birth rate remains the same, even if we don't do the PGT, which means PGT is a conditional thing for them. So this has to be borne in mind when we are going for PGT in recurrent miscarriages without having the genetic cause. Here, why we are doing PGT is that it will reduce the time to pregnancies, because it will precisely select the good embryo and reduces our effort. So this is the most important useful point about doing PGT in these cases. So, but we have to look into the evidence how a patient has to be with recurrent pregnancy loss or a miscarriage has to be evaluated. The diagnostic evaluation starts after 2 pregnancy losses as per the definition. So initially the guidelines were proposed by RCOG, then ASRM, and the recent ones are by ESHRE. Parental karyotyping, as we were discussing, is not routinely done, but it is done. Has to be done conditionally as per the ESHRE guidelines, which means that if the they have a prior child with congenital abnormalities, or already they know that the prior pregnancy loss, the products of conception are showing some unbalanced or balanced translocations, yes, definitely there is an indication to do the parental karyotyping. Or in unexplained pregnancy losses also, we can go for parental karyotyping. And again, products of conception cytogenetic analysis is not routinely recommended in all these 3 guidelines. But again, ASHRAE guidelines say that it can be used for explanatory purposes. Uterine evaluation is the mandatory thing in all the 3 guidelines. The preferred method for doing an uterine evaluation, initial evaluation, is a 3D ultrasound followed by advanced procedures according to the need. So 3D can actually distinguish between the various uterine anomalies too. The most important evaluating point is antiphospholipid antibodies. All the guidelines unanimously recommended. So ASHRAE recommends LAC, ACL antibodies along with anti-beta-2 glycoprotein 2. Thyroid function, again, TSH with TPO antibodies is strongly recommended by ASHRAE. And again, prolactin. Prolactin is recommended, testing is recommended only when there are symptoms of hyperprolactinemia like oligoamenorrhea. So the again, the endocrinal conditions like hemoglobin A1, HbA1c is not clearly recommended by the guidelines. Hereditary thrombophilias, again, it is conditional. That means only when indicated it has to be done, as we have discussed. Sperm DNA fragmentation in unexplained causes and also for explanatory reasons. Then PCOS, insulin resistant markers like fasting insulin, all these things, they're not routinely recommended. Luteal insufficiency testing, luteal phase defect testing is also not routinely recommended. Ovarian reserve, as we have been discussing, actually it is not routinely recommended, but it is obviously better to have an outlook about all these things. So vitamin D deficiency, general advice is given according to the ASHRAE guidelines that it has to be supplemented for all the women who are planning pregnancy preconceptually, that too with the history of the miscarriages, because vitamin D is supposed to do immune potentiation. So having considered all these guidelines and having understood, so we at our hospital, we have actually formulated a checklist for all the patients with the recurrent pregnancy loss, where initially for both male and female, we look into the lifestyle related risk factors, especially overweight or underweight, or smoking alcohol, and again, vitamin D supplementation we do, and endocrinal evaluation along with the uterine cavity evaluation, preferably with ultrasound first, followed by again hysteroscopy and biopsy, if at all the cause remains unexplained even then, or if we find some abnormal pathology in the basic 3D ultrasound. Lupus evaluation is mandatory. Congenital thrombophilic profile, again conditional with only history. DFI and karyotyping, as we were discussing, in unexplained causes, in prior anomalies, all these things which we have discussed. Ovarian reserve and is an important factor which has to be actually included in our checklist, which we do routinely. So again, products of conception is one point which has been extensively discussed in the modern or newer guidelines, which have not been actually formulated as mandatory in the ASHRAE or ASRM guidelines by chromosomal microarray. So the products of conception are better when compared to the karyotyping because of the culture contamination aspects are considered. When contamination aspects are considered, POC with CMA are far better rather than doing karyotyping for the couples, because even when normal karyotype is there, there is a chance of having sporadic miscarriages. So considering all these things, there is a new algorithm which is developed by Pappas and Putte very recently. They suggest the evaluation after second miscarriage for first trimester losses. Again, they have involved the screening of weight, lifestyle check, cavity check, APS hormones, followed by products of conception with chromosomal microarray instead of karyotyping or any other genetic tests. So again, if we find any abnormalities in the above said 1, 2, 3, 4 conditions, we can manage accordingly. Prophylactic vitamin D is again suggested here, and psychological support is the most important one. So after this is the most important one. which is the recent one which has to be included in the evaluation of the patients with pregnancy losses. When you are going with the products of conception evaluation, if the products of conception are aneuploid, that means it could be even sporadic cause also. We can wait for a few more pregnancy losses, maybe 1 or 2, without further testing, and we can do with the expectant management. Supposedly they are having the products of conception are euploid, which means we have to look for the other causes for cavity or endocrine etiologies. If at all they are there, they have to be addressed. If not identified, again they have to be considered as unexplained causes. And unexplained cases, definitely we actually tend to do hereditary thrombophilia screening, DFIs, parental karyotyping, luteal deficiency testing, or we should consider uterine conditions like endometritis, hysteroscopy, and all. So if at all the products of conception, they are found to have unbalanced translocations or inversions, definitely parental karyotyping would be abnormal for either of the partners. So genetic counseling is important, and we can use the help of PGT-SR, structural rearrangements, for eliminating the embryos with these structural abnormalities and giving a good embryo, so leading to the live birth. So, but again, this has to be outweighed with the expectant management. Again, the important thing is that these parents still have the chance of conceiving normal baby, which means the cumulative live birth would be the same. The only important thing which helps us is it reduces the time to pregnancy. So this has to be borne in mind, and patients have to be considered expectant versus PGT treatment in all these conditions. So after third miscarriage, if no testing has been done, the patient comes to us. So investigate and manage according to the same algorithm. So these are the 2 examples which I'm going to put forward, which have been done in our hospital. We are regularly doing PGT for our indicated patients who have come for IVF. So this is one interesting case which I thought would be useful for most of us. A male with 35-year age, female 26. They're non-consanguineous, but they have the history of recurrent molar pregnancy, recurrent pregnancy losses. So when I've tried to look into the literature, I have found an association of genetic mutation, NLRP7, along with certain other mutations which are actually inherited to the babies. So when we thought of looking into this genetic mutation, whether it is present in the parents, we did couple carrier screening. So particularly when the couple is non-consanguineous, but the previous etiology is unknown, so we have done couple carrier screening. So fortunately, both partners are found to be carriers for this mutation. So, and also there is a good history that pedigree analysis revealed that the patient's mother had a history of IUDs, maternal aunt has history of 1 molar pregnancy, strong family history is suggestive. So all these has led us to go into the genetic evaluation. So this actually the history itself gives us a clear indication that it could be an autosomal recessive condition. So since she's affected with recurrent hydatid form mole and husband is also carrier for the same, and it's giving us a pattern of autosomal recessive as per the genetic condition is there according to that mutation, which is inherited as autosomal recessive condition. We explain the patient there is 50% risk in each pregnancy that child is carrier and 50% chance that a child will be affected. So, so they were counseled with IVF with self gametes. PGT for monogenic disorders was advised to select and transfer embryos which are free of mutation, followed by again prenatal genetic testing at 16 to 18 weeks. This is one more application of PGT SRs for structural rearrangements and for the aneuploidy. We have a patient with infertility actually. And there are also certain patients with miscarriage history with the same profile. The male partner is 39 with severe oligoasthenoteratospermia. And in cases of severe OATS, we do karyotyping because they are found to be associated with certain genetic abnormalities like translocations, and sometimes Y chromosome deletions are also found. So we do karyotyping Y chromosome deletion for severe OATS. And we found this translocation, and hence what we know from the genetic background is that carriers of balanced translocation have a higher chances to produce embryos with unbalanced translocation, that which is more lethal. So to detect that unbalanced translocation, we have gone for PGT-SR. And again, we try to separate these embryos with unbalanced translocations and euploids, and a euploid embryo, which probably could be a carrier of balanced translocation, also could is possible. It is possible. So such embryos can be transferred. So these two important cases actually will give us an idea how the PGT can be utilized in cases of the miscarriages with genetic issues too. So to summarize, the take-home message would be, even after first miscarriage, even though guidelines that do not actually advocate the diagnostic test, we can actually look into the risk factors and try to attempt to identify the etiology. And the evaluation with diagnostic tests can be started after second miscarriage. We have to also consider newer guidelines for complete evaluation, because with the introduction products of conception into our testing panel, about 80 to 90% of the miscarriages could be explained with some reason. So thereby it leads to identification of the correct etiology, which means we can avoid unnecessary usage of the drugs like progesterones, like heparin, like low molecular, low dose ecosprin. All these things need not be irrationally used for all pregnancy loss patients. So the cost of the healthcare system is also reduced by all these measures. So the important crux is, for all the patients with miscarriage history, is tender loving care with reassurance. Never give up the hope. Thank you.
Dr. Monica Gupta, would you like to give us expert comments, please?
Very well explained by Dr. Shri Harsha Rauri. She explained everything very nicely. What we are doing every day, recurrent abortion is a problem for IVF specialists as well as for the general doctors presenting for the general. Hello. The patient and the doctors who are practicing generally. What is basically missed is unexplained infertility. We have to give a certain answer to the patient. Okay, what is going to happen next time? Because patient is very much worried, and here the importance of tender loving care and psychological support is very important. What we were giving in the initial days, that is again come up even after 25 years, because positive attitude is very, very important in the doctor as well as in the patient. When we have to explain her, even if the chances of abortion is 25%, there are 75% chances of having a live birth. That is very important. And you have to focus on that. And we are taking care of what has happened to you and what is the reason, and we are going to treat it. You have to keep a confidence on the medical system. And now the medical system is so advanced that we can find out many causes. And what we have seen, when the abortion has happened, the POC's evaluation is almost the time the neglected patient becomes so devastated that she goes off and she never wants to have POC's evaluation. So we have to counsel her. Okay, this is important, because even if you have lost this baby, if we find the reason, we can save your next baby. That is very important. And you have to go for the evaluation of the POCs, even though it is expensive because of the cost factor. Many people, they avoid it also. But we have to make a good counseling of that. Here the work of counseling comes for the abortion, psychological support, counseling, along with the medical treatment is very important. Thank you, society, for giving me opportunity to talk on this topic. Thank you very much.
Thank you, madam. Wonderful take-home messages. POC evaluation, which is going to be the order of the day in few coming days. That POC evaluation will definitely improve the next outcomes and identify the cause. With this, we come to the end of the session. Any other comments from the presidents or secretaries? We are welcome there.
About the vaccinations, there was one question which was in the chat box. That's by Dr. Sunita Naidu. Sunila Naidu. She says, can we give flu shot? But it was around that time when the vaccination talk was on.
Yes, madam, it can be given.
Ramnath Gaud, sir, would you like to add some comments or anything, sir? Or we'll conclude the session. Monica, madam, can you take that question, madam, as a chairperson for this?
What is the question? Please repeat.
Kindly explain when to order microarray test in fetus.
I can't get it. Let me.
When to order microarray test in fetus. In the recurrent pregnancy loss, which trimester would you like to advise it? Microarray test. Like amniocentesis, madam. Microarray test in fetus, madam. It's a genetic test we do in the fetus, especially when you have a recurrent pregnancy loss. When you want to know, then we can do products of conception, or if the fetus is growing, and if there's a second or third trimester losses, we can do an amniocentesis and find out. These are the methods we do it. Monica, can you give the vote of thanks?
Hey everyone, I feel honored and privileged to get the opportunity to propose vote of thanks for the special program APOGS ABHYAS webinar by the state of AP in association with Alwar, in association with societies Alwar, Ajmer, Bijapur and Bellary. And I thank our chief guest, Dr. Venkateshwar sir, President Guntur OGS and Professor and HOD, OBG Guntur Medical College, for constantly guiding us through this program. And I thank our today's speakers, Dr. Rama Kaj Madam, Dr. Richa Gupta Madam, Dr. Shivakumar sir, Dr. Sangamay sir, Dr. Sriharsha Ravuri ma'am, for sharing valuable information with us. And I thank our chairpersons for today's webinar, Dr. Jamnath sir, Dr. Shobha madam, Dr. Preetam Kotari madam, Dr. PV Hanumantrao sir, Dr. Monica Gupta ma'am, for sharing the thoughts today. And I thank all the presidents and secretaries of Rajasthan, Ajmer Society, Dr. Preetam Kotari ma'am, Secretary Dr. Rajesh Sharma sir, Alwar Society, Dr. Richa Gupta madam, Secretary Dr. Akriti Jha ma'am, Bijapur Society President Dr. Subhash Ramana Gowda sir, Secretary Rajasri madam, and Bellary Society President Dr. Jambunath Gowda sir, Secretary Usharani madam, and Guntur President Dr. Venkateshwar sir, Secretary Dr. Umashankar sir, and thank you for giving me this opportunity.
Thank Jagsonpal for conducting this webinar in a very nice way. I thank you all the panelists, speakers, presidents, and the audience for making this webinar a grand success. Thank you all. With this, we conclude the meeting. Thank you.
Thank you, sir.
Thank you.